that, let me know. Excellent. Abdulia from Wilmington. And then we also have Diego. Diego, if you're able to type in where you're coming from and your role, then I will be oriented to who is participating in the training today. All right, well, we'll go ahead and get started. So I'm Brian Hurley. I am an addiction psychiatrist. I'm the medical director of the Department of Public Health Division of Substance Abuse Prevention and Control. Tasha Dixon will be joining us a bit later. And Norma, you want to introduce yourself briefly? And thank you, Dave.
Yeah, sorry. Good morning. I'm Norma Mtume, a community engagement specialist for this project.
All right. There's no commercial support for today's activity. Neither Norma, myself, or Tasha are being paid by any commercial interests. So we're not going to try to sell you anything today. So let's kick ash. The objectives of today's project are to compare and contrast the medications available for smoking treatment, explain how to run a weekly smoking cessation group, how to apply CBT techniques to support people who use tobacco products, and describe the spirit of motivational interviewing and demonstrate through some activities how to support people making behavior changes. Really, the goal is we want to support you to help the people you work with to stop smoking. This was actually done as part of a research project looking at how capacitizing or supporting smoking treatment services at 9 DHS-run community health centers and 6 DMH-run community mental health centers compare to 2 DMH sites and one DHS site and 2 DMH sites that had been comparison sites or treatment as usual. So these were the site distributions for the way that we clustered the project. We finished recruitment, and so at this point we're analyzing the smoking behavior of the county patients that we had enrolled. And interestingly, the way that we ran it was not that the study actually didn't pay for treatment. Both DMH and DHS have clinicians that were running smoking treatments. So that wasn't, in other words, it didn't actually pay for the clinical intervention. What the grant paid for was trainings like this and the development of the kick ash manual. That was all part of what the study paid for. But the actual clinical services were all done in county facilities using county resources and are sustainable. So part of the strategy of continuing to do these trainings is to support this team continuing to support patients who have tobacco use disorder. These are the email addresses of the folks who have been involved. So I'm up at the top, my public health email address. This is Norma's email address and Tasha's email address, and then Luz and Brianna, who have been our smoking navigators, are listed there. I'm not going to spend a ton of time talking about the health impacts of smoking. I sort of trust that folks that are here are aware that use of tobacco products is bad for you. If there's any questions on that, let me know, but it's associated with lung cancer, heart disease, COPD, etc. But actually part of what I do want to do here during our time together this morning is try to get into some of the hearts and minds of how we work with people who use tobacco products. So with that, I have a video. Oh, you know what I'm going to do? Sorry about this. It's always, I have to make sure it's optimized for a video clip. All right, cool. If you can't hear, I'm about to play the video. If you can't hear it, please chat in, and that way I can correct.
The word African woman, woman of my land. What's the word African woman, what the search Africa is, what the sword that special.
Hi, I'm Norma Mtume, and this is my story regarding community engaged research.
More recently, I've been thinking about medical care in South Los Angeles from a historical perspective. I grew up in Los Angeles in a poor neighborhood. From childhood to early adulthood, I received some basic primary care at a local doctor's office. However, when we didn't have insurance and cash was low, it was off to the old county hospital where a basic visit could take an entire day. I remember traveling a long distance to see a doctor, especially for specialty care. We would take 3 buses to get to the hospital and the clinic until a county facility was built in our more immediate community when I was 22 years old. I remember smaller local hospitals where my siblings were born and some county clinics, but they didn't provide the care we needed. Only recently did it dawn on me that many black doctors lacked the admitting privileges in major hospitals. Consequently, after providing prenatal care and other care in their offices, they sent their patients to hospitals where they were allowed to practice. I have been interested in the body and numbers for as long as I can remember and preferred math and life science in school. I love physical education and running street races with the neighborhood kids. I decided that I wanted to teach math and physical education when I grew up. Consequently, I began Cal State University at Los Angeles with a physical education major and a math minor. As time went on, I realized that it wasn't just the body I was interested in, it was overall health. Not much had changed since I was a little girl. I wanted to help make a change to ensure poor people could be well. In my sophomore year, I became involved with neighborhood social services and helped to start and direct a free clinic in South Los Angeles. My interest grew to include a more holistic approach to health care, and I returned to graduate school to study more about health and mental health. During my career, I helped to establish and serve in leadership for 2 other community medical and behavioral health clinics in Los Angeles and Berkeley, California. 8 years ago, I became involved with Charles Drew University and the University of California at Los Angeles Medical School's research endeavors around community engagement. I was invited to work with the schools and their students to help them develop best practices to engage with their patients in the community. I work with basic science researchers who are hard at work looking for causes, developing treatments, and hopefully finding cures for many illnesses and diseases that plague our poor and under-resourced communities, like those in South Los Angeles. Here, research is being conducted with and not on communities. As an individual with a diverse background, I participated as a full partner on non-traditional research teams in what is called community engaged research. I serve as a community representative on advisory boards that oversee the overall projects. I have conducted interviews, facilitated focus groups, and participated in planning events to disseminate research results back to the community. Unfortunately, things still haven't changed much since I was a child regarding poor health outcomes in my community. Poor people still have the highest rates of disease, disability, and preventable deaths. For instance, the decrease in smoking cessation rates across the nation still are not translated to lower rates of tobacco use in African American communities. My work over the last 8 years has culminated in my latest project where I will be working with a research team to implement smoking cessation services in Los Angeles County mental health and health services clinics. I no longer consider research as something mysterious, but as something that warrants my attention and involvement. I work now to help with educational and health systems change to reverse these trends to ensure a longer and better quality of life for those in my community. Health science research studies are important because they help us to better understand illness and disease and what preventions, interventions, and treatments might work best for various populations. Most community engaged research is paid for with your tax dollars. So why not join me? Learn more. Get involved.
Good morning, everyone, and thank you for joining us today. I want to give a special shout out to you, Abdulia Hernandez from Wilmington Community Clinic. I worked with Dee, your executive director, and Dr. Bean was someone who's been on your board for many years, since back in the 90s. And congratulations on your recent anniversary that you're celebrating. So thank you for joining us. Again, I'm Norma Stoker Mtume, and I'm Community Engagement Advisor for this project. I would like to help set the stage for us to be thinking about all the information being presented today, how it might relate to the patients or clients that we're serving, and what we'll do with the information after this convening. Many of you who have attended our trainings and smoking cessation symposiums in the past have heard parts of what I am about to say. And I continue to repeat it because family and others in my community continue to suffer from illness, disability, and preventable deaths that are primarily caused by smoking. I've spent most of my life and career building and helping to run nonprofit organizations in South Los Angeles and similar communities. By similar, I mean communities where health disparities abound. As you all are probably aware, smoking has been shown to have a direct causal or significantly exacerbating effect on many other illnesses and diseases. Moreover, research shows that smoking can be detrimental to all systems of the body. Sorry, just a second. As community engagement advisor, my key role in this project is to help ensure that we keep the real goal of our work at the forefront. We do the work we do to help our patients and clients have a better quality of life. The bottom line is we want to help save lives. But some days, personally, I feel like the casualty of trauma and disparities. And these are some of the reasons. My maternal and paternal grandmothers died from strokes, and one also had diabetes. One of them smoked. My mom was killed in an accident while working in LA County. An elevator crushed her. One brother was murdered about 6 months after my mother passed. Another brother, a smoker, died from colon cancer after a botched surgery while he was incarcerated. One more brother had a series of strokes, and we suspect it was a stroke that caused him to crash his car on the freeway one day, and shortly afterwards, he died from internal injuries. He was a smoker. I'm just getting started. My sister died at the age of 50 about 8 years ago. She had Parkinson's, diabetes, high blood pressure, and asthma. Did I say she smoked? Her husband passed away 4 years ago from cancer. He was a smoker. My dad, who was always my biggest cheerleader and hero, died from lung cancer 13 years ago. And I didn't even touch on the mental health and HIV, AIDS cases in the family and dear friends, most of whom also smoke. For my dad, in 6 months, I watched him go from a robust 125-pound, fun-loving grandpa to 95 pounds and too weak to stand on his own. He covered the mirror in his own room because he couldn't stand to see his own reflection. And to emphasize the addictive quality of nicotine, he had 3 heart attacks before he quit smoking. But by then, unbeknownst to any of us, the lung damage had already occurred. Also, one of my dearest friends since 7th grade died 3 years ago after a bitter battle with cancer, lung cancer. She also smoked and had the hardest time quitting. And this year, I add another casualty. Late last year, I add another casualty. My first cousin and childhood playmate was placed into hospice, and a couple of weeks later, she passed away. She had lung cancer and smoked. And now I'm adding to this list my bonus mom, a stepmom who was placed in hospice late last year with breast cancer. The last few months passed away a few weeks ago. She was a smoker who stopped some years ago. She also had kidney cancer and lost a kidney. So you see, my work with this smoking cessation project is personal. I realize that I'm but a step away from being one of the statistics we'll hear about today, and very similar to folks that you're working with. I want to help see that others don't have to watch family and friends suffer and die from smoking-related illnesses as I've done. The best plan is to prevent ever starting to smoke. The second best plan is to intervene as soon as possible. I believe that integrating smoking cessation services into medical and mental health clinics is moving Los Angeles County in the right direction. I'm very proud to have been a part of this team and look forward to better outcomes for patients struggling to change their behaviors around smoking. And I figure that I must be still standing and have pretty good health at 73 years old for some reason. And so I continue to do the work. Thank you.
Thank you, Norma. Any questions before I move forward? I know we'd welcomed some folks earlier. I just want to welcome Ron from Mid-Valley and Eddie from Juvenile Correctional Health Services. It's good to see you both. This morning is going to go until approximately 11:30, so for like an hour and 10 minutes. And then we're going to take a break. Or sorry, 2 hours. Sorry, 2 hours and 10 minutes. And then we're going to take a break. And then we'll get into the Kick-Ash manual. We're going to talk about medications for smoking treatment. Then we're going to talk about motivational interviewing, which is how we talk to patients about change. Break, and then the Kick-Ash manual, which is actually the sort of the manualized cognitive behavioral therapy-based treatment to help people who use tobacco products transition to becoming non-tobacco product users. So that's the flow of the day. So once again, Brian Hurley, I don't have any financial conflicts of interest. I was, when I did the slide deck, president-elect of ASAM. I'm actually now the president of the American Society of Addiction Medicine. ASAM has tobacco use disorder intervention guidance, and I will not be unbiased with respect to ASAM, our practice guidance. So I just wanted you to, it's not a financial conflict, but I just wanted to let you know that is a conflict of interest. So those of us that work with patients have the opportunity to act. Most people use tobacco products, and if you just survey people who use tobacco products, most people don't want to use tobacco products, or at least they don't want to use them forever. But without assistance, the quit rate, the chance that when somebody stops smoking, that they will stay stopped when they want to, right? I don't mean like the chances of somebody who smokes is going to spontaneously stop smoking is close to zero. You have to want to stop in order to stop. But even people that want to are really only able to sustain quit attempts 1 out of every 20 times, right? 5% success with a kind of unassisted quit attempt. Now, assistance doubles the chances that somebody's going to stay quit. That's great, right? So from 5 to 10%. But that means that there's a 90 to 95% or I guess failure rate or a return to use rate or relapse rate, depending on how you define it. So in order to get somebody to stop smoking, the key is to not quit quitting, right? Because if every quit attempt is 5% successful unassisted, 10+% successful with assistance, and then with additional medication support, you can get numbers up to in the like teens, 20% success rate with any given quit attempt. The key is you have to keep trying, right? Because with each successive quit attempt, you learn something, and so that's really how smoking works, or smoking treatment works. Is you quit, you stop smoking for a period of time, and something happens. And then the something that happens, whether it's you were triggered by coffee, whether you had an upsetting event happen, whether there was an exciting thing that happened, you want to celebrate, something happens and you sort of return. So what happens next is you try to quit again, and this time you've learned where your triggers are, where where the pitfalls are. And we, in helping professions as counselors, pediatricians, social workers, people that help patients, we can more than double the chance of somebody's success with meds and with counseling and with support in order to be able to get people through. So I think of smoking treatment as a learning process that happens iteratively. So people have to continue to quit. And so I think the numbers are somewhere between 9 to 12 quit attempts in order for somebody to really stay quit. So what I tell patients is, I would recommend well, first of all, assess the person's readiness to quit, and when they're ready to quit, support them in their readiness to quit, and then help keep them from quitting, right? Help, because it takes several quit attempts in order to typically succeed. And we're one of many influences on people. And one of the things about to the kind of tobacco landscape now is a lot of the newspapers and TV and radio and the community, the kind of smoking cessation movement has really made smoking much less convenient. And its regulation is such that it's much less promoted, it's much less accessible, it's much less sort of in people's faces and in people's lives in comparison to how it's been in the past. So, we are a key influencer to help people who develop tobacco use disorder, but a lot of the social context around tobacco product use has been constructed to help people actually keep from starting even in the first place. This is the smoking cycle. People smoke a tobacco product, and by smoke a tobacco product, I don't just mean inhaling cigarettes, burning dried tobacco leaves, which is in cigarette smoke or in cigars. In this case, it could be vaping, but whenever you inhale an intoxicant, it goes into your pulmonary vasculature, which is the blood vessels lining your lungs. And that goes directly into the left side of your heart, which then goes directly into your brain. And so it's actually faster to smoke things than it is to inject things into your body in terms of like time to, between use and your brain receptor. And it takes about 7 seconds after you inhale a drug for it to reach your brain. And nicotine causes dopamine release, which is associated with pleasure. People feel relaxed and good. But nicotine has a half-life, and so it saturates the brain, but then you metabolize it out, you feel craving for another cigarette, and then you smoke again. And if this happens frequently enough, this is the smoking cycle. This is the same cycle, just in blue. And what the medications seem to do is they make that craving period more manageable, right? That period between when the nicotine levels drop and when somebody uses again, it makes that period less uncomfortable for somebody. And it also makes the use of nicotine less rewarding. So that's where the medications seem to really be focused. So for smoking cessation strategies overall, right? I mentioned this earlier. We've got meds, we've got counseling, we've got support, right? Meds helping support people's physiologic transition off of tobacco products, counseling helping giving people skills and strategies, and support being everything else. Support being, somebody's social network and people in their lives. Many people use tobacco products, have other people who use tobacco products in their lives, which can make it hard to quit because when you leave a space to go take a smoke break, with a group of people, that's very reinforcing, not just in terms of the addictive substance, but also in terms of, it's a social time with your friend group. So part of treatment is adjusting people's supports so that they have fewer pro-tobacco use supports and more smoking cessation or abstinence supports. And we've got, again, the meds that do the physical and the behavioral treatments. A lot of the Kick-Ass manual is a behavioral treatment, motivational interviewing is behavioral treatment that help people actually support the behavior change of becoming a non-smoker. And ideal treatment addresses both. That said, I'll continue to do behavioral treatment if somebody won't take a medication. Everyone has to take a medication in order to quit smoking. And the converse is also true. I don't withhold medications just because a patient isn't in counseling, right? Like, in other words, I want people to have access to both. They're both on the menu, but the patient can make a decision around what they're going to take advantage of. Here are just a litany of behavior change interventions. We've got the standard screening, assessment, intervention, referral. We've got cognitive behavioral therapy. Actually, physician advice appears to be particularly effective because people connect it to their health. Individual counseling can be effective if it's more than 4 sessions and more than 10 minutes per session. Psychoeducational groups, peer support, there's a variety of population-tailored self-help materials, and then the California Smokers Helpline. Many of us are familiar with something called the 5 A's. The 5 A's came from a now somewhat dated, but still relevant, clinical practice guideline for treating tobacco use disorder. The 5 A's are to ask, advise, assess, assist, and arrange. The first is you ask about people's tobacco product use in a neutral, normal way. It's not like, you don't smoke cigarettes, do you? That's not actually asking. That's in some ways judging or telling. Can you tell me about your use of tobacco products? And I would think quite broadly, chew, vapes, cigarettes, cigars, any other tobacco products you're using. Then advise the person to change. One of the most healthful things you can do for yourself is to reduce and then potentially eliminate your tobacco product use. Well, what do you think you're going to do, right? So I advise you to reduce and then eliminate your tobacco product use. But what is your willingness to do a change attempt? And they might say, Doc, I'm never going to quit using tobacco products. Okay, that's where we are. Versus, I know smoking's bad for me. It's just so hard to quit. Okay, that's a slightly different place. Versus, I've really committed to quit, and I just really need your help in figuring out an exact strategy. But that's part of that assessment, that middle A. Then assist with that's relevant to where the person is, right? So if the person is ready to cut down, I support them in doing that. If the person is ready to quit, I support them in doing that. One of the issues with smoking cessation is this like fixation on quitting. If I say, are you ready to quit? And the person says no, I'm left without some important information because I don't know if the person is ready to cut down but not quit, or if the person is not ready to change their tobacco use at all. So I actually think it's important to assess what changes is the person willing to make, even if they're not really ready to make a full quit attempt. Because I will support people in reducing their tobacco product use, even if they're not ready to stop, and then arrange for follow-up. And then each visit, where are you at with tobacco product use? Remember, the healthiest thing you do for your health and wellness is to cut down and eliminate tobacco product use. What changes are you thinking about making? And then assist people in doing that. And that happens each time. The 5 A's, again, this is not new. It's been around for 15 years. What was also part of that, like this tells you the what, but this isn't actually the technique for like talking to people about change. Motivating patient readiness is the 5 R's, which we're also in the guidance, but less well publicized. And the 5 R's are, how relevant is tobacco product use from the patient's perspective? How important is it to them, right? And what is relevant? What about tobacco product use is relevant to somebody? I might think, tobacco product use, strokes, heart attacks, cancers, right? That might be my areas of focus. For the person I'm talking to, that may not be relevant to them. They might not even thinking about their health, or at least the health consequences. They might be thinking about yellow teeth and the financial strain and the smell. They might be thinking, it drives me nuts. I can't comfortably walk up 2 flights of stairs because of how much tobacco products I'm using. Any of those things are like I'll take what I can get. It's more important that I understand the patient's priority and the reasons that they see to potentially reduce their tobacco product use. In other words, people are so much better convinced by their own ideas than by my ideas. So understanding how relevant is tobacco product use from their perspective. What's the risk seen by the patient of continuing to use tobacco? What rewards does the patient see of changing their tobacco product use? Are there any roadblocks that they see? And then repeat each visit. So in this assist in attempt to cut down, and also in kind of the assessment part, we have the 5 R's. How is tobacco product use relevant to the patient from their perspective? What are the risks that they see? What are the rewards that they see? What are the roadblocks in the way that they see? And how do I contextualize smoking from their perspective? So how do I make a patient quit, or how do I motivate somebody to quit? I actually have to first understand what motivation or readiness are they bringing to the table. And that also means that there are patients that have no interest in changing the tobacco product use, and I have to accept that, right? I can spend time trying to give somebody reasons, but if they're like, no, like I've decided I'm going to use tobacco products. Part of the techniques is accepting that and then bringing it up the next visit. Has anything shifted in terms of your readiness to change your tobacco product use? It does our patients, from my perspective, a disservice to put tobacco use in social history part of the note. I actually put it as part of medical history, because Smoking affects the way we metabolize a bunch of medications, and I'm a psychiatrist, so psychotropics in particular. It's not actually nicotine that seems to do this. It's the polycyclic aromatic hydrocarbons that come from inhaling ignited smoke. We don't see the same level of activation with vaping because polyethylene glycol doesn't seem, which is the common solvent in vapes, doesn't really seem to trigger the same enzymatic activity. Nonetheless, when people's tobacco product use changes in the upward or downward direction, we tend to see an increase in medication metabolism. So the more you smoke, the faster your medication metabolism. The less you smoke, the less. And so this can affect the blood levels, psychotropics, and a bunch of other medications. And actually, I have to give it to the Australian government. The New South Wales government actually has a really helpful list of a bunch of medication interactions with tobacco products. Now, many people who continue to smoke are not, or I'll put it this way, are served by a mental health system that rarely documents tobacco use disorder. That tends to maintain a low awareness of tobacco quit lines. Many states, like hospitals and substance use treatment centers, don't directly offer smoking treatment. So all of you now here on this call are now aware of the Kick It California website, launched a year and a half ago. This is the successor to 1-800-NO-BUTS. So if you are familiar with the No Butts program or 1-800-NO-BUTS program, Kick It California is the, again, successor to that. They have updated phone numbers, although 1-800-NO-BUTS will forward to this phone number, so you can still use that number, but the updated phone numbers are 800-300-88, 800-300-8086 or 800-600-8191, which are the phone numbers in English and Spanish, respectively. All right, so with that context, let's talk about the medications available for tobacco use disorder. We really only have 3 molecules. We have nicotine, varenicline, and bupropion. Nicotine is nicotine, right? It is a replacement therapy. The idea is you give somebody nicotine to replace the nicotine that they're not taking in through use of tobacco products. Varenicline is a high affinity partial agonist. You take it, it binds the nicotine receptor stronger than nicotine does, but only partially activates it. It's the buprenorphine of nicotine. And then bupropion, which metabolizes to hydroxybupropion, which is a antagonist of the nicotinic acetylcholine receptor, and essentially diminishes the reactiveness of that receptor to nicotine. So all of these things make nicotine less rewarding. With nicotine, you're sort of maintaining somebody's nicotine tolerance. So even if they smoke on top of it, they're not going to feel it as much. Varenicline is going to block nicotine that you take from binding to the nicotine receptors, as is bupropion. The difference is varenicline actually gives you a little bit of a nicotine effect. So nicotine, bupropion, varenicline, that's how they work in a nutshell. Now, nicotine replacement therapy comes in 5 formulations. We have the gum, lozenge, patch, nasal spray, and inhaler. On the LA County DHS formulary, we have gums, lozenges, and patches, but not the nasal spray or inhaler. Those need to be ordered non-formulary. For those of you working in the community, all 5 of these can be covered by Medi-Cal, and then bupropion and varenicline are also covered by Medi-Cal. I'm prescribing you a patch to help you quit smoking. Please wear it over your mouth. Knowing nothing other than what I had just said, which of these medications is most effective?
The most effective medication is the one that the patient is willing to use.
That's exactly right. The most effective medication is the one the patient takes. It does not matter what the clinical trials show, right? Clinical trials select for patients that are ready to take medications. That's part of what you sign on the dotted line for as a clinical trial patient. So I'm not saying clinical trials are irrelevant, and I do have clinical trial data. But what I am saying is it does not matter what the clinical trial data show if the patient's not ready to take it. So if the patient says, I do not want pills, then bupropion and varenicline are kind of off the menu because they're not going to take them. No matter what the clinical trial shows, right? If the patient doesn't take it, it's not effective. So this is our menu of options. And there's certain, combinations that seem to work better than other combinations. And again, there's a recommended medication strategy to that end. But if the patient says, I'll do the patch plus the gum or lozenge, great. If the patient says, I don't want to use gum or lozenge, I want to do the patch plus bupropion, fine, right? Like understanding what the patient is ready for is more important than coming up with like an idealized medication strategy. So the biggest factor to consider when treating tobacco use disorder is patient preference. Patient preference. Then, different clinicians have different familiarity with medications. Some medications are contraindicated for some patients. So bupropion, somewhat famously, can cause seizures. So in people that have either epilepsy at baseline or who are about to have a seizure because they're about to stop drinking suddenly or using a benzo suddenly. It's not that alcohol or benzos are contraindicated. It's just you have to monitor for the seizure potential. And then if a patient's done really well on a medication or combination in the past, that might be a reason to go back to it. If someone's doing really poorly on that in the past, it'd probably be a reason to avoid it. So those are the factors to consider. So this came from the VA handbook published, 9 years ago. Again, still a relevant, it's still relevant, that shows that placebo alone essentially like doubles quit rates from 5% to, in this case, it came up to 14%. This is 6 months. The data is a little bit less impressive at 1 year, but nonetheless, a 13.8% response with placebo. Short-term gum treatment alone only modestly increases that. It isn't until you get to the patch, the lozenge, or the gum for longer than 2 weeks that you get abstinence rates in the 20s. Varenicline is the most effective single agent, right? If you can only pick one, varenicline seems to be the most effective single agent, but you can get even higher success rates through combination treatments. So the patch plus the gum or lozenge, the patch providing a kind of baseline level of blood nicotine, and then the gum or lozenge that you can use PRN for a smoking urge, that seems to work really well. And that same strategy you can do with varenicline plus the gum or lozenge, or the patch plus bupropion, right? Like combination therapy should actually be more the rule than the exception. And I look at county prescribing data, and what I see is a bunch of people that just take the patch. They just take the patch, and that's just the med, as opposed to the patch plus. And I would encourage all of us here to be thinking combination therapy first, as opposed to just one med. Or now, if the patient's only going to take one med, fine. That would be a good reason to just do a monotherapy. But in what I offer people, I say, hey, look, the evidence is really best when people take 2 or more options. And so I provide some guidance. The only combination I tend not to combine is the patch plus varenicline, although there are clinical trials studying that combination. They show, well, some trials are positive and some trials aren't. So it's not like wrong to do that. But varenicline plus the gum or lozenge, which is a combination I use all the time. Part of the reason for this is the patch, and that's the pink line in this graph. The patch really takes a couple hours to really kick in, come to what we call steady state. And so in nicotine from cigarettes is this like quick on, quick off, right? You get this spike. And so what the patch does is it increases the nicotine level so you smoke less, right? So those spikes become less frequent. But if I can do the patch plus the gum or the lozenge, or short-acting as needed nicotine product that somebody can get their like blood level of nicotine up quickly, it's a logical combination of both the patch to provide a basal level of nicotine, and then during a craving, give somebody a shorter acting PRN nicotine product that they can use in order to be able to get their nicotine level up, with the goal of avoiding going back to cigarettes, right? When somebody's craving a cigarette, if they can pop a gum or a lozenge and kind of get their nicotine level up quickly, it can help curb them from returning to tobacco product use. The patches comes in 7s, 14s, and 21s. Again, steady nicotine blood levels that is absorbed through the skin. I advise patients to take it off at night. Wearing a nicotine patch overnight does seem to reduce cravings in the morning, but it doesn't seem to actually change smoking behavior in the morning. So there's not a lot of actually like behavioral evidence that it seems to help, but it does cause nightmares. And so I've had patients sort of complain of nightmares when they wear the patch overnight. So I just have them take it off when they're asleep. So put on the patch when you wake up, take off the patch before you go to sleep. This is kind of the standard instructions. It can cause skin irritation, but the skin irritation is not from the nicotine, it's from the adhesive. So if somebody has skin irritation from the patch, I just have them switch the brand that they're using. That typically resolves it. I do recommend having gum or lozenge or a nicotine product like the inhaler or nasal spray next to somebody wherever they sleep, because people are going to wake up in nicotine withdrawal. So this gives them something that they can use right away to get their nicotine blood levels up, as opposed to using a cigarette. And then oftentimes, if people shower in the morning, you put on the patch after the shower. The patch does come off easily with sweat or water. So that means if somebody is going to the gym or going swimming, either using a spare patch or wrapping their patch in surgical tape. You can absolutely start in patients who've not stopped using tobacco products. It's a misnomer the patient has to be ready to quit to start nicotine replacement therapy. The decision-making process I use for nicotine replacement therapy is: one, does the patient have tobacco use disorder? And two, are they willing to take nicotine replacement therapy? If the answer is yes, they have tobacco use disorder, and yes, they want to start nicotine replacement therapy, they get nicotine replacement therapy, even if they don't want to stop smoking, because it will reduce their tobacco product use on its own. It just, there's this like really elegant study looking at people with tobacco use disorder, and they put IV lines in everybody, and they didn't tell them what they were looking for, and started giving people different doses of nicotine through the IV line. And regardless, the higher the dose of nicotine, the lower the smoking level was, right? People just smoke less when they have more nicotine in their bloodstream. And it is absolutely recommended to combine it with the gum or lozenge. How do you dose the patch? You dose the patch to meet or even a little bit exceed the amount of nicotine somebody takes in from cigarettes or from vaping. So with cigarettes, it's pretty easy. You estimate 1 milligram of nicotine per cigarette. A pack has 20 cigarettes. So if you're a pack a day smoker, that equates to a 21 milligram patch, right? 20 milligrams, you get a 21 milligram patch. A half pack a day smoker, somebody that smokes about 10 cigarettes a day, gets a 14 milligram patch. A quarter pack a day or 5 cigarette a day smoker goes to a 7 milligram patch. If somebody smokes, 8 cigarettes, I go to the 14 milligram patch, right? I aim to exceed the amount of nicotine they're coming in. If they are using a vape product, I have to know what the product is and the strength of the product and how long it takes the person to go through their vape pod. If they have, they're using a 30 milligram pod and it takes them 2 days to go through it, that they're a 15 milligram a day smoker, they get a 21 milligram patch. So that's with vaping, you just have to know the product they're using and how much nicotine they're taking in from their vape product each day. That helps guide the patch. Then the gums and lozenges come in 2 and 4 milligrams. If somebody is a 10 milligram or less a day smoker, I tend to default to the 2 milligram gum or lozenge. If they're a 10 or over 10 milligram a day smoker, I tend to default to the 4 milligram gum or lozenge. The truth is, I just say, we've got a weaker version, a stronger version. Which one would you prefer? I default to patient preference. I've been told, or patients have told me, oh, the gum, it doesn't work for me. Oftentimes, if somebody says, I use the gum and it doesn't help, it doesn't seem to cause any relief, the reason is oftentimes because of how the patient is using it. So the way that you use the gum is you chew the gum and then push it against your cheek. And it's the pushing of the gum against the cheek that actually gets nicotine into your bloodstream through your buccal mucosa or through your cheek. It does not work if you chew it. So if you chew it, it'll dissolve, it'll saturate your saliva, and then we swallow our saliva. So then it goes to your stomach, where your stomach, what is the right term? Denatures nicotine, right? The stomach essentially digests nicotine before it has a chance to absorb. So chewing nicotine products will not generate any relief. Chewing and then parking the gum will. So nicotine has kind of a peppery taste. So when you chew it, people should have that peppery taste. Then you push it against your cheek and have it sit there. You could even kind of rub it against your cheek to have the nicotine absorbed. When the peppery taste goes away, you know that the nicotine has been absorbed on the outside coating of that gum. So you chew it again, refresh the coating, and you do that back and forth, right? This sort of chewing and then parking and then chewing and parking until there's no more peppery taste left, and you discard the gum. That is how you use the gum. Same principle with the lozenge, except the lozenge you don't chew. So with the lozenge, you just push it against your cheek and just kind of like rub it there until the lozenge dissolves, and that's how you get nicotine into your bloodstream. Inhalers are, they're like vapes in the sense you're inhaling something. They're very much unlike vapes because there's really no solvents in inhalers. These inhalers are these like thin plastic tubes. They have a wick saturated with nicotine. You draw air through the wick and it takes nicotine kind of off the wick and into your lungs. So it's not heated the way that vapes are. And there's no real like solvent like polyethylene glycol that is superheated at a heater that gets it in. So there's really no smoke in an inhaler, but there is all of the behavior of taking something and inhaling. So that is a disadvantage of the inhaler. So you're not breaking the habit. The nasal spray is just, literally a bottle of dissolved nicotine. You spray it into your nose, the nicotine absorbs through your nose. It can cause nasal congestion and burn a little bit. So it's not super comfortable, but there are people who prefer it to other things. The way that I prescribe is the patches, gums, and lozenges are all kind of first line, cheap, generic, over the counter, actually, and for people who can go buy it, but Medi-Cal covers it, and so I prescribe it to patients who are covered by Medi-Cal. And then the inhalers or nasal spray are like, you get to that if you have not done well with other nicotine products. So bupropion is an antidepressant. It is contraindicated in those with seizure disorders or with active bulimia. The standard product insert is you start a week or two before the quit date. In actual practice, I'll start it whenever I identify somebody who has a tobacco use disorder. Same principle. You have tobacco use disorder. Is a person who want bupropion, and in this case, are there any contraindications to bupropion? Assuming the answer to those all line up, which is yes, tobacco use disorder, yes, they want bupropion, no, there's no contraindications, then they get started on bupropion for 150 a day for about 3 days, and then go up to 300. 300 milligrams once a day is a kind of standard dosing. Now, Zyban, which is the brand name version of bupropion SR, which is sustained release, not extended release. The SR version is the version that was FDA approved for tobacco use disorder, and that's a twice-a-day med. The reason that I don't prescribe the Zyban formulation, I do the bupropion XL, which was really a med for depression, is because it works just as well as the SR version, right? In head-to-head trials, the SR and XL, once a day the XL versus 150 twice a day of the SR, about equally effective. And the adherence is better, right? Once a day meds, people take have a better shot of taking consistently than a twice a day med, where people oftentimes forget about that afternoon dose. Bupropion is super activating. It can cause tremor. It can cause insomnia if taken late in the day. So I have people recommend people take it when they first wake up, and you can safely combine it with nicotine replacement therapy. So again, NRT, patch plus lozenge plus bupropion is not an uncommon menu that I'll offer a patient. This is just the area under the curve of the immediate release, twice release, and extended release formulation, which shows roughly equivalent areas under the curve for each of these medications. This is the bupropion is the medication with the most precautions and contraindications. So the big thing with bupropion is seizure. So people that are on a med that might cause them a seizure, you just use bupropion with risk. There are hepatic dosing adjustments. It's off-label for adolescents. There used to be a black box warning for treatment emergent neuropsychiatric symptoms that seem to be associated with psychiatric symptoms associated with quitting smoking, not from the medication, and it was removed in 2016. The contraindications are active seizure disorder, active bulimia, anorexia nervosa. Somebody's about to stop drinking a high volume of alcohol or about to stop using a sedative suddenly. Somebody's on a monoamine oxidase inhibitor, which is contraindication. And then if somebody's on Wellbutrin, you don't use Zyban, right? Because they're both bupropion. And then last but not least, varenicline, the most effective single agent. It is a high affinity partial agonist at the alpha-4 beta-2 nicotinic acetylcholine receptor. It provides mild activation, right? So it is a partial agonist, but not a full agonist. So it causes a little bit of a nicotine effect, helps with cravings and to avoid withdrawal, but binds so strongly that it prevents nicotine from activating the receptor. That also means that if somebody goes from the standard dosing of varenicline off suddenly, they'll go into nicotine withdrawal. So usually the rule of thumb is you titrate up and taper off. The standard titration is 0.5 milligram once a day for 3 days, 0.5 milligram twice a day for 4 days, then 1 milligram twice a day thereafter is the standard dosing. You can prescribe a starter pack. You can also prescribe the standard pack, which is 1 milligram twice a day with instructions. I do either. The standard dosing is for 24 weeks. I have some patients who take varenicline for much longer than that. So you're by no means restricted to 6 months of treatment. The standard side effects of varenicline are nausea, sleep disturbance, headache, farting, constipation, taste alteration, and there was a black box warning around neuropsychiatric symptoms. Again, it's pretty rare. We're now, I think it's resolved. There was a supply shortage and we had to import varenicline, generic varenicline from Canada because the brand name Chantix had nitrosamines that were over the minimum allowable according to the FDA. Nitrosamines are not toxic, like it's not like poisonous. If you take one pill, you then die. But in aggregate, if people take nitrosamines for many years, it is associated with increased cancer risk. So I believe Pfizer is now reformulated Chantix and it's out in the community in a much less nitrosamine enriched form. You'll hear people say, oh, these medications that can make you crazy. This is this great article published in 2019 in JGEM, which essentially was said, look, irrespective of medications for smoking treatment, people who use tobacco products are more likely to experience neuropsychiatric symptoms if they are anxious, if they've had a history of prior suicidal ideation, and were identified as white. People use tobacco products with a psych history, female sex, younger age, and greater severity of tobacco product use predict neuropsychiatric adverse events. So it doesn't actually seem that whether it's bupropion or varenicline seem to be strongly associated with a ton of adverse neuropsychiatric events. It's the quitting smoking is tough. And in people that have risk of neuropsychiatric events, such as mood symptoms or suicidality, can experience those things in the context of that stress. And I first learned how to prescribe varenicline in a clozapine clinic with people with very severe mental illness. Varenicline really, it's more effective than NRT for people with mental illness, according to this is thank you. Nicotine and Tobacco Research article from 2020, and this is UK data. And there's the Eagles trial really interrogated varenicline and any neuropsychiatric effects which might be present that really said, look, the benefits of stopping smoking outweigh the risks. There are mental side effects, right, that can happen, but there were not psychiatric hospitalizations or completed suicides, and the benefits of smoking are substantial. So here is the medication strategy I referenced earlier. If somebody uses tobacco products, but they're not using them every day, they kind of vape or smoke PRN, then they get the gum or lozenge that they take PRN, or inhaler or nasal spray if they haven't done well on the gum or lozenge. If somebody is smoking 8 or fewer cigarettes a day, 7 milligram patch plus 2 milligram gum or lozenge plus bupropion, or varenicline plus the gum or lozenge plus bupropion. I tend not to combine the varenicline with a patch, but I can combine the patch, short-acting nicotine, bupropion, or varenicline, short-acting nicotine, bupropion. As the amount of cigarettes go up, the dosing of the patch and the gum go up. So a 19 to 15 cigarette a day smoker gets a 14 milligram patch, 2 or 4 milligram gum or lozenge based on the patient preference plus bupropion. 1 pack a day smoker gets 1 21 milligram patch, 4 milligram gum or lozenge plus bupropion. If they're a 2 pack a day smoker, they get 2 21 milligram patches. You're just continuing to dose up the amount of NRT to meet or even exceed the amount of total nicotine they take in through vaping, cigarettes, or cigar usage. Most patients with mental illness need meds at higher doses, longer durations, and in combination. When we talked about bupropion, bupropion is a very activating antidepressant, so don't use it in people with bipolar disorder who aren't on a mood stabilizer. During pregnancy, psychotherapy is first line, and there's some research that nicotine replacement therapy may be less effective. Now, the U.S. Preventive Services Task Force said there's not really enough evidence to recommend medication interventions for smoking treatment in pregnant people. There's just not a lot of research. That said, there's also limited research of perinatal harms. Really, the only thing that has been shown is an increase in diastolic blood pressure and skin irritation from the patch. And the conventional wisdom is for during pregnancy. I would rather the person take NRT than continue to smoke. During pregnancy, the metabolism of nicotine is increased, and again, NRT becomes less effective at standard dosing. Okay, what about electronic nicotine delivery systems, or ENDS? So electronic nicotine delivery systems, which is essentially trying to use vapes to help people quit smoking, is not recommended during pregnancy. There is now kind of a body of research suggesting that it's not that difficult to transition people from using conventional cigarettes to vapes as a harm reduction strategy, which is, I think, I understand that, like, it's a reasonable harm reduction strategy because the polycyclic aromatic hydrocarbons with conventional smoke is really the things that cause cancer and inflammation. The polyethylene glycol from vapes is probably less harmful. Less harmful is the key here. It's not safe, right? Polyethylene glycol and vaping is not healthy. It's not safe. In the sense that, there's hospitalizations associated with interstitial lung injury. So I don't like, if somebody's going to make a quit attempt, I'm going to default to using FDA approved medications. But if somebody says, hey, look, I'd rather, I'm thinking about transitioning from cigarettes to vaping. Okay, but now I'm likely to be working with somebody with a vape use disorder as opposed to a cigarette use disorder. What about quitting with somebody's in addiction treatment? Actually, if somebody's able to quit smoking while they're in addiction treatment, the odds that they're going to remain abstinent from their primary substance, from their alcohol or methamphetamine or heroin or whatever else they were using, goes way up by 2.5 times. What's interesting about addiction treatment is most addiction treatment programs don't include or focus on tobacco. It's this sort of idiosyncrasy of the legacy of how tobacco addiction is conceptualized different than other addictions. Just looking, this is a study from a little over 10 years ago, but about 14% of people who entered addiction treatment stopped smoking, but interestingly, 11% of people who entered addiction treatment as non-smokers started smoking. And that is, addiction treatment seems to generate tobacco use disorder because of how frequent tobacco use disorder is. But in it, and there's this conventional wisdom of, well, in addiction treatment, you can address your tobacco use disorder, but maybe you'll do that later. That conventional wisdom is quite wrong. In a meta-analysis, again, a significant increase in the likelihood of somebody becoming long-term abstinent from alcohol and illicit drugs goes way up when they quit smoking. And so smoking cessation during treatment enhances SUD treatment outcomes and does not impair the presenting problem. So what about vaping? Do I recommend electronic nicotine delivery systems as a tool? Not as a first-line tool. It's sort of, if somebody says, look, I'm not ready to quit smoking, but I'll transition to vapes. Okay, you can transition to vapes. But again, then now you have a vape use disorder, right? You don't get now I'm left with using these same medication strategies and tools to help people, quit vaping as opposed to just quit smoking. Here are some resources, which is the federal website, smokefree.gov, the California Smokers Helpline, KK California. There's a 12-step program, Nicotine Anonymous. Most of my material comes from the UCSF Smoking Cessation Leadership Group, and then the Behavioral Health Coalition, Behavioral Health for Tobacco Free, which ASAM is a coalition member, so conflict of interest there. And I don't, again, recommend as healthful light or natural cigarettes. They're just as addictive and carcinogenic. I don't recommend smokeless tobacco. And again, e-cigarettes have been shown for people who use tobacco products to, you can go from using conventional tobacco products to vaping, but the safety of vaping is, again, not well demonstrated. So don't quit quitting. This is my email address if there's any questions. And I'm seeing some comments about blurry screen. I'm sorry that the county internet is not clearer. Any questions about the content?
Hi, it's Pen. Thank you so much, Dr. Hurley. It was super helpful. I'm just wondering, when you had mentioned like sometimes you have tobacco users who then become like nicotine vape users. How do you then counsel them on quitting that? Do you use the same
exactly the same way that you would counsel them on
medication?
smoking? Yeah, so meds, counseling, support.
Would it be the same medications that you had listed before?
Yep. So here's the recommended medication strategies. This was pulled from the DHS best practice. If you look, it says corresponds to 8 or fewer nicotine cigarettes or equivalents. The equivalents refer to the amount of nicotine coming in through vaping. So it's in fact the exact same medication strategy. You just have to use slightly different math to transition from vapes to milligrams of nicotine, because it's not 1 milligram of nicotine per vape. You have to figure out the brand and how quickly they're going through their pods.
I understand. Got it. Thank you so much. Appreciate it.
Yep. Other questions? All right. We are going to take a 9-minute break. I'm going to empty my bladder, and then we will resume at 10:15. Thank you. Motivational interview. You should see a screen that says motivational interviewing. I will also be playing some videos during this, so as before, if a video comes on and you can't hear it, please chime in. I don't have any financial conflicts of interest here. ASAM does do a lot of motivational interviewing courses, so it is a conflict of interest, but it's not. I don't personally benefit from more motivational interviewing sort of sales or any of ASAM's work in this area. So here's the educational objectives. What I will say kind of from the outset is motivational interviewing is about arranging conversations where you evoke from the patient their ideas, values, and readiness. So sometimes I get asked, how do I make my patient change? Or how do I get them to see it my way? Or how do I, if I'm the one doing all of the talking, if I'm the one doing the explaining and the justifying, that's not motivational interviewing, and I'm doing it wrong. Motivational interviewing is effectively arranging or structuring conversations so that people talk themselves into change based on their values and interests. And if I'm doing this well, I will be, if they're doing this well, the patient will be doing most of the talking. This is just a quick video on the origins of motivational interviewing.
Denial and resistance in people, if you think about that I went through, is not a property of the pathology of the individual, okay, but says something about the relationship. My 15-year-old lies to me consistently, but not to his best friend. Do you see the point? Yeah, okay, so, but you know what I'm saying. You've got to be very careful. And what Miller and I shared then and now is that if you shift your style, this is the basic observation, the motivation to change improves in front of your eyes. And that shift in style is not just a technical matter, it's your attitude towards this person. And so associated with that style shift is a whole lot of things that you saw in Conversation B, which we'll have a look at in a moment, again. But I think which can be captured by this. Try not to judge, try not to blame, try not to label the person. Try and be respectful, reflective, as your colleagues have said. And the motivation to change can come from within them. They have the energy and the motivation and the good sense to change inside them, and much of the capacity and skills to make change happen if you give them the space to do that. And that's a very different approach to what I saw in that addiction treatment unit, and Miller had noticed in addiction treatment settings in the United States, where his stories were the equivalent of mine. I mean, there were some stories that he told me and still tells me that truly make me shocked.
All right. Oftentimes we think of change as being something we have to like do, for somebody. But change is a process that people actually do for themselves, and we can help, right? We can be with people, but ultimately, it is like people are on their own change process. Now, change is natural. It occurs all the time, and the conversations and the treatment and the interactions we have with people really does facilitate change. Ambivalence is normal. People really do feel two ways about a lot of things. Smoking really helps me relax, but I know it's bad for me. I can't imagine what I would do with my free time if I didn't have a cigarette in hand. But I can't afford it. I know I don't, like the way it affects my teeth. I mean, like, in other words, a lot of people feel two ways. And so the attitude is, tell me more, help me understand. What, as opposed to, yeah, it's really bad for you. It can cause cancer. You need to quit today. Because if what you do is push, it invites the person to push back, right? What it invites the person to do is say, but I like smoking. I'm not ready to quit. And they are much more likely to do the things that they hear themselves say than the things that they hear us say. So paradoxically, it works against us. If we push patients and all they do is defend, then what will be in their head is defending. Resolving ambivalence is really the key to change, right? It's exploration. So it means rather than saying this person's pre-contemplative or unmotivated, it's, well, people are always motivated for something. For what is this person motivated? What does the person want? I'm going to define change talk. Change talk is defined as self-motivating speech. It's things that people say that's in the direction of change. It's, I could change, I want to change, I should or ought to change. That's all examples of change talk. The same talk is I can't, I won't, I love smoking, I want to smoke more. And the more the person talks about change empirically, the closer they are to changing. The more they talk against change, the less likely they are to change. Now, there's a range of styles, and a lot of us work in medical settings which are very directive. I've diagnosed you with an ear infection, here's your eardrops. I've diagnosed you with, this illness, here's your treatment, right? We teach, we assess, we prescribe, we lead. And there are, many of you might be, who worked in behavioral health might be very familiar with a, what would you call it? A following approach, right? What are you here to talk about? What would you like to talk about? What are you interested in? You just sort of listen, you seek to understand, you go along with. Motivational interviewing is really neither of these things. It's not particularly directive. You're not assessing, prescribing, and leading. But you're also not just following. You're not just sort of like going along with whatever the patient is saying. It's a guiding style. It's strategic. You are in the ways that you respond to patients, providing some guidance about where to go next. Now, I do want to talk about the technique of how to do that, but the technique is actually less important than how you sit with patients. And this is the spirit. The spirit of motivational interviewing goes by the acronym CAPE. It's compassion, acceptance, partnership, and evocation. I've already referenced acceptance, which is if you bring up a topic and the person is like, I love cigarettes. I love everything about cigarettes. I love the cancer. I love the heart disease. I love the smell. I love the cost. If I could literally only inhale cigarette smoke from this day forward, I would do it, right? I can accept that person's likely to go out and smoke, right? I may not like it. I may not agree with it, but I can understand it, right? I can understand it. So I have to accept that this is where people are. It's based in partnership. It's being with people, right? As opposed to I'm the physician, you're the patient, I know what to do, your job is to go do it. Partnership is I may know things about medications and counseling and support and treatment, but you know your life. Let's come together as mutual experts to solve the problem of what to do about what's going to be best for you. And it's based on evocation and spending time really evoking from somebody their ideas, their values and understanding. And in compassion, which is really the most important part, it's actively prioritizing to the person's needs, right? I have compassion for their experience. Without compassion, right? Motivational interviewing, I can accept and partner with people and evoke and still be kind of a slick salesperson. I can be manipulative, right? If I'm just looking to evoke somebody's experience for the purpose of selling them something. It's really compassion that separates motivational interviewing from other types of sales techniques. Another way to think about it is a good motivational interviewing. I say something and invites the patients to say something. The patient says, I wish people would get off my case because of how much I'm smoking. They don't know how stressed out I am. And I might say, you're really stressed out and you want to find some way of feeling better without always smoking, right? They didn't say that. I said that, but it invites the person to now pivot into how do I feel better without smoking? It's sort of I'm inviting somebody into that space, as opposed to, what do you mean you have to quit smoking? But I'm not ready to quit smoking, but it's bad for you. But I don't know if you've ever had an interaction that felt like a wrestling match. A good motivation interviewing is like a dance and not a wrestling match. To help talk about the spirit, I have a video from Brene Brown.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Have any of you seen that video before?
Yes, it's a really good video.
Any whatever that. So Ron, you have, and then forgive, I wasn't tracking the voice, but any reactions?
Yeah, I think the disconnected part of sympathy is spot on. It's it's laid out in that vignette. It's once once you start to basically feel sorry for somebody else, then they pull away, you know, and they're like, or, you know, or if you try to, like she said, silver lining it, that then they're like, yeah, I don't want you to fix it. I just need someone to listen to me, you know. So yeah, it's really good.
So in motivational interviewing, there are 4 processes. The first process is, are we talking to each other? Engagement. Now, I have patients that are in the room, sitting, watching me, but are not engaged. How do I know if a patient is engaged? Arms folded, looking to the side, not really, you know, they're watching me in the sense that they're in the room, but they're not necessarily paying attention. And if I ask them something, they might give me a 1 or 2 word answer. Yeah, nah, whatever. You know, like, it's hard to make real progress if somebody's disengaged. So the first step in any motivational interview is, are we actually walking together? And this, I might spend a lot of a session actually engaging if that's an issue. I'll give you an example. I used to see patients in LA County Jail, patients who were, from what I can tell, for very righteous reasons, very angry to be there. And they would be assigned to see a psychiatrist. And I would walk up and I would sort of tap on their cell. Hey, this is Dr. Hurley. I just want to come by and say hello. And they would not even acknowledge I was there. Right? They were alive. They're breathing, they're moving, but they're just not. And it doesn't matter how good my technique is. It doesn't matter. It's not a me issue, right? Circumstances outside of the exam room shape whether or not we're even engaged. If we're engaged, where shall we go? Can we agree on an area of focus? Is smoking even on the table, right? And if somebody is like, yeah, I'd love to talk about smoking. I love everything about smoking. I'm never going to stop smoking. Okay, maybe we'll find another area to focus on, right? Because I may not make, like, this may not be an area where there's actually ambivalence. What motivational interviewing does is structure conversations when somebody is ambivalent about something. If they are not ambivalent, motivational interviewing does not make them want to change. It only structures the conversation when somebody is ambivalent around selectively reinforcing change talk, right? But what it doesn't do is take the youth that loves vaping, loves everything about vaping, wants to vape all day, every day for the rest of their life, and make them not want to vape anymore, right? That, like, motivational interviewing works well for ambivalence. So what do you do if the person's not ambivalent? You might do something called an ask tell ask, which is how to give information advice, and I'll go through that. But then ultimately, in the spirit of motivational interviewing, saying, okay, I understand this is not an area of priority for you. I'd like to bring this up next time. Would it be okay if I did that? Right? Like, and then move on, because what motivational interviewing does not do is make people change. It only structures your relationship such that when somebody is ready to make a change, to support them in doing that. And how do we do that? Through evoking. So engaging, shall we walk together? Focusing, where should we go? And it's a negotiation. It's my priorities and your priorities. Can we agree on an area to go together? And then evoking, why are we going there, before we get to planning? And this is counterintuitive. Oftentimes we think, assessment, plan. I've determined what's necessary. I'm going to present the plan to somebody, as opposed to spending the time of, is this person even with me? If so, is the topic that I think is relevant to them? Have I done the work of understanding their, the relevance, the risks, the rewards, the roadblocks? Have I done the 5 R's, which is kind of the evoking section, before I get to the plan? Now you might say, Dr. Hurley, this will take 45 minutes. I don't have this kind of time. I'd say there's sometimes where you're spending the entire time engaging. You might not ever get to planning because the person's not ready for planning. There's other times where, you might go from engaging to focusing to evoking in like 2 sentences, right? It could take maybe 15 seconds to get to evoking. But so in my mind, I'm just attentive to each of these processes because they're kind of linear, but they're also like, engaging kind of happens throughout, and focusing is not a one-time event, and evoking is also part of engaging. So they're also kind of, it's not just like a one-time, like we're engaged and now we're focusing. Like they do bleed into each other. But in my head, I'm attentive to, is this person talking to me? If so, are we in agreement on what the issue is? Or, I don't mean like full alignment, but I mean like, can we agree on the overall topic? And have I done the time to understand things from the patient's perspective to put together a plan that's likely to be workable? I have a video about this, but just to be clear, oh, that is not what I wanted to show. It's the confluence of these four processes that best describes motivational interviewing. So I have a video illustration.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's gonna stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever gonna stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
No, see, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to see things my way.
What does this have to do with motivational interviewing? The video about the nail.
It sounds like the woman is not yet in the frame of mind to talk about the nail.
Yeah, she's not ready to talk about the nail. So for him, it's like, it's so obvious. Pull out the nail. And she's not going to engage with him around that. Right? So he needs to put in the work to to actually like, yeah, that sounds really hard. Like spend the time evoking. Now, here's a question. Have you ever had a situation where the thing that was needed was so obvious and yet the person wasn't ready to do it?
Yes, I have.
Yeah, it happens all the time, right, Ron?
Yeah.
Sorry,
yeah.
Ron, go ahead.
No. I'm just going to say and he knows where he is. He knows what he needs, but he just wasn't ready to. A person who's addicted to heroin for over 25 years and still avoiding rehab, and so but you just gotta wait. 3 different outreaches, and I'm still waiting on that. Waiting on him, basically. So,
well, for the person that's addicted to heroin, one of the things that they could do to help at least keep from dying of a xylazine or a fentanyl overdose is to take buprenorphine, which doesn't require them to go to rehab. But that aside, you're right. Somebody might not be ready to do like a full abstinence-based treatment, right? And it happens all the time with smoking. This is too hard. I know I should quit, but it's really, really hard. We hear that all the time. All right. So when we're engaged, I think of engagement as providing the platform. The stronger the engagement, the stronger the platform. Now, focusing is this ongoing process, and it's not a one-time thing. It's are we setting a direction with a specific achievable goals? And specific achievable goals might be smoke 1 less cigarette a week. Fine, I'll take it. Right? Like it might not be full abstinence. But really the deal with focusing is, can we come up with an agreement on again on like an area for where to go. Now, focusing might imply, like if you're in a health clinic, as an example, right? Like they're probably, like talking about health is relevant or important. So it isn't just like whatever the patient wants to talk about. And there's, like again, in focusing, there's the guiding. The patient's agenda is important, but the clinician's expertise, right? Like what I do in my role and with the setting is also important. And so these things get balanced. And you might say, look, if the person is not ready, or if I really just want to tell somebody what I think, what do I do? And I say, you can do ask, tell, ask. How do you give information and advice while still embodying the spirit of motivational interviewing? Well, the first thing is you ask, can I give information and advice? Or I have something I'd like to share with you on this. Is it okay if I share it with you? And you might say, well, why do I need to ask permission? And the reason to ask permission is it primes the patient to hear you. It primes the patient to actually listen to what you have to say. Then you give a limited amount of information in clear language. And then you ask, so what do you think what I just said? What do you think? So it could be, person says, hey, I love vaping. I love everything about vaping. I'm going to vape the rest of my life. Okay, I have some thoughts on that. Would it be okay if I share my shots? Sure, whatever. Whether you vape or not is up to you. The human lungs are built to breathe clean air. And so when you're vaping, you're putting yourself at risk for lung injury. Whether or not you vape is up to you. But I just want to make sure that you know that I can help you cut down or eliminate vaping when you're ready to do so. So what do you think you might do? Okay, doc, thank you for letting me know. Or would it be okay if I brought up vaping the next time we meet? Just checking with you on it. And then kind of like let it go, as opposed to, but what about this thing? And what about that thing? And what about this reasons? And what about that? Like if you just start into this lecture, you're probably going to lose engagement. So we've talked about the spirit, we've talked about the 4 processes. I do want to talk about some of the core skills. Like what do you actually do? Now, the core skills of motivational interviewing are not that different than general counseling skills. So there's not actually any like secret to what you do during motivational interviewing. The difference between how you use these skills in like patient-centered counseling or other, types of counseling skills is the selective attention to change talk. That's what makes motivational interviewing. So I'm going to go through the core skills. These are not new. This is just how you talk to people. But it's how you use those skills in relationship to change talk that makes it MI. Okay, so open-ended questions. Open-ended questions are questions that can't be answered by yes, no, or one-word response. It invites the person to reflect and elaborate. Can you tell me about your smoking is an open-ended question. Do you smoke cigarettes is a closed-ended question. Open-ended questions are more engaging. Closed-ended questions feel more interrogational. That's open-ended questions in a nutshell. So I mentioned ORs, open-ended questions, affirmations, reflections, and summaries. Affirmations. Affirmations are a statement that is about the existence or truth of something that recognizes some fundamental, like, underlying good, and it often starts with you. So an example of an affirmation: patient shows up to their appointment, I say, you honor your commitments. If a patient is dressing well, I might say, you take pride in your appearance. This is different than good job for showing up on time. I like the way you look today. Like that's praise, and praise is on the surface, and praise is sort of an expression of approval or admiration. It also suggests that you're in a position to give praise. An affirmation is like somebody starts yelling at me, I might say, you just tell it like it is. You don't pull any punches. That's an affirmation. As well as I like the way you said that. So affirmations usually start with you. Praise usually starts with I. I might have to retire this example because at this point, not everyone has seen the movie, but there's this classic movie called The Wizard of Oz, and it features Dorothy. Dorothy is a farm girl from Kansas with a dog named Toto. This is her picture. If any of you have seen the movie or have some familiarity with the story of The Wizard of Oz, can anybody think of any affirmations for Dorothy?
Despite the situation you find, or I'll frame it this way: despite the situation you find yourself in, you have a positive attitude about your circumstances.
So, if I could rephrase that, Ronald, you maintain a positive attitude in the face of adversity.
Oh, yes, awesome.
Yeah, that's an affirmation. It's a great affirmation. You maintain a positive attitude in the face of adversity. Any other affirmations that we might offer, Dorothy?
You make friends easily.
Mm-hmm. You prioritize your relationships. You're loyal to the people in your life. Those are excellent affirmations. Any other affirmations we might offer, Dorothy? What about Elphaba, the Wicked Witch, the West? Are there any affirmations that we might offer Elphaba?
Once you I guess you are an excellent planner, and once you make a plan, you stick to it.
Yeah, you see things through. You're tenacious. That's a great affirmation. Any other affirmations we might offer Elphaba?
To be honest, I haven't seen the movie, but I have seen the musical Wicked. So
Yep.
if there's anything related to that,
Sure.
I would say you don't let other people hold you down.
That's a great affirmation. You don't let people hold you back. You do what it takes. So here's the point I'm making is you don't have to be, in the Wizard of Oz, Dorothy is the hero, Elphaba's the villain. In the musical Wicked, it gets a little more complicated. But in the classic movie, Dorothy is the hero and Elphaba is the villain. You don't have to be a likable character, right? You don't have to if you have a patient that drives you nuts, you don't have to be this sympathetic character in order to find something to affirm in somebody. So that's the point I'm making is you can almost always find something to affirm in somebody, and it can really change the tenor of the relationship in the room. Reflections. So reflections are statements where you take what the patient says to you and you say it back to them. And simple reflections are literally where you just say back to somebody what they said to you. So if somebody says to you, I smoked two packs of cigarettes a day, you would say back to them, you smoke 2 packs of cigarettes a day. Or you could rephrase it slightly. If the person says, yeah, I find myself vaping a lot. I vape most of the time. I might say back to them, you vape a lot. It's just you're repeating something back to them. Part of the role for simple reflections is if you don't know what to say, oftentimes we resort to asking questions. What's the next piece of information I want? But in natural human communication, actually, most of us aren't asking questions. We're reflecting. So I would say, if you're ever stuck and you're not sure what to do next, just say what the person said to you back to them. Because you can't just keep doing that the entire time, but it does buy you a little bit of time, and then it invites the person to kind of elaborate on what they said rather than doing a question, which if you just keep asking questions, it tends to feel more like an interrogation. So simple reflections are one style, but the art of motivational interviewing really is using complex reflections. Complex reflections are where you make a guess about what is true for somebody and then reflect in that direction. So I'll give you an example. I'm sick and tired of people going on and about my smoking. I'm stressed out, and that's why I smoke. I might say, you are looking for a way to feel better rather than smoking. I'm guessing that that's what's underneath. That's what's kind of, underneath the surface there. I might be wrong. And if the person says, no, I didn't say that at all. Okay, you didn't say that at all. Use a simple reflection, right? But if I'm right, it can move the conversation in that direction without asking a question. You can reflect the feeling. If somebody's like, God, I'm sick and tired of people going on about my smoking, I might say, you're exhausted. Yeah, they just, you don't understand how tiring this is. You can also use a metaphor. So they're like, hey, I try and I'm just not getting anywhere. I might say, yeah, you're just treading water. Right, it's a metaphor. You can use an amplified reflection. This happens a lot with smoking. I might say something like, what thoughts do you have about changing your smoking? And the person says, what do you mean? And I might say, well, you could double the amount you're smoking. So to go from 1 pack a day to 2 packs a day, or from 2 packs a day to a carton a day, or you could hook up like a scuba diving suit where you're just filling the tank with cigarette smoke and just breathing that in and out all the time. And if I've done this amplified reflection right, the person would probably laugh and say, well, no, I can't. I can't afford a carton a day. Like that would be ridiculous, right? And it would be bad for my health. And now all of a sudden, I'm getting change talk. By amplifying in the direction against change, I can get the person to reflect on why they wouldn't want to smoke more, or why they wouldn't want to smoke forever. You can get change talk that way. Or a double-sided reflection. On one hand, smoking really helps you relax, and on the other hand, it's bad for you, right? And so you can use a double-sided reflection, which ends in the direction of positive change. Essentially, the way that I think about reflections is the simple reflection is what's on the surface and of like the metaphoric iceberg, but what's underneath is the thoughts, the feelings, the emotions, the values. That's where I want to get to, and that's where I'm aiming my complex reflection. And I don't know what it is. I'm only hypothesizing or guessing, but I'm aiming my complex reflections in that direction. So, patient says, right now, smoking doesn't make me feel better the way it used to. In fact, I feel worse now. You might say, smoking makes you feel worse now. Or, smoking is no longer helping you feel better the way it used to. Or, in the past, smoking helped you feel better. Now it makes matters worse, and you want to find some way to feel better instead of smoking. That's an example between like the echo and rephrase, which just pair it back to somebody what they said, to using double-sided and complex reflections to move the conversation. And during a conversation, patients will give you change talk. Well, I really wish I didn't smoke this much, or I really wish, I had more money in my pocket, or I really, whatever, right? They'll sort of give you all of this stuff. And then a summary is where you take all of that change talk and selectively summarize the change talk. Any questions about the technique of motivational interviewing? All right. So in motivational interviewing, patient language is a particular focus. And so I've talked about change talk, self-motivating statements. But what you'll actually hear is the patient say, I want to change, I could change, I've got good reasons to change. And when we hear it, it increases the patient's own motivation for change and increases, like empirically, the probability that people will actually make whatever change they're talking about. You can separate change talk into 2 basic domains. One is called preparatory and the other is mobilizing. The metaphor here is preparatory is sort of like revving an engine, and then mobilizing is like the vehicle beginning to move. And the acronym for this is DARN CAT. DARN stands for desire, ability, reasons, and need, right? Desire, I really wish I didn't smoke as much as I do. I could smoke less. If I didn't smoke, I'd have more money. Or I gotta quit smoking. I gotta, right? That's darn. None of that is person's actually making a change yet, but it's all like a desire to change. They could change, they've got reasons to change, or they need to change. And CATS is commitment, activation, and taking steps. I made that appointment. I started the nicotine patch. I called the California Smoke Helpline, or I have the helpline number, and I'm gonna call it next week. Those are like commitment language, activation language. It really supports that somebody's really ready to make a change. Most of us are probably familiar with the Prochaska di Clemente model of pre-contemplation, contemplation, preparation, and action. And the motivation for interviewing Hill maps onto this, right? So pre-contemplation, you won't hear very much change shock, but in contemplation, you're beginning to hear, somebody is in this ambivalence range. I desire, ability, reasons, or need. You'll hear somebody say, I want to, I could, I've been thinking about, it would be nice if, it'd be better for my health if, those are the things that you'll hear. And then I've decided to commit, I picked up the prescription, I made the appointment, I called the smokers helpline. Like, that's the commitment, activation, and taking steps. I've stopped categorizing patients into pre-contemplation, contemplation, preparation, action, and I'm much more interested in, like, what are they saying is in the darn area, and what commitment language, if anything, am I hearing in the commitment area. So here's the desire, ability, reasons, need, commitment, activation, taking steps, acronym for darn cat. Change talk is where we want to be, right? During an interview, we want the patient to be giving us change talk, but how? What do we do that gets the patient to talk about change talk and for us to then selectively reinforce it using our counseling skills? Well, we could ask evocative questions. We could use the readiness ruler. We can do decisional balance, which is pros and cons. We can ask for elaboration. We could query extremes. Query extremes is, do you plan to smoke forever? Do you want to increase the amount you smoke, right? Or looking back when you weren't smoking, what did that look like? Looking forward, if you were to stop smoking, what would that look like? And exploring goals and values. Let me cover the readiness ruler, because not everyone knows what that is. The readiness ruler is a technique where you ask, on a scale of 1 to 10, how important is it for you to change your smoking? And let's say somebody says, it's a 6. You say, okay, it's 6 out of 10 important. Why is it 6 out of 10 and not 3 out of 10? What made you say 6 rather than 3? And the reason that you give the patient back the number they gave you and then ask, why is it that number, not a lower number, is the next thing they should say is why it is important to them, and that is change talk. The reason you don't say, why is it a 6 and not a 10, is the next thing they'll give you then is sustain talk, why it isn't important to them. And I'm more interested in why it's a 6 and not a 3 than in why it's not more important. I want to know why is it a 6? Why did it get to that part of the ruler? Why is it important to them? Because that's where the change talk is. But wanting to make a change and saying it's important to make a change is not enough. In addition to recognizing how important it is to change smoking, I have to know how confident somebody is. How confident you could change your smoking. If somebody's like, well, I don't know, quitting smoking is really hard, it's a 4. I could say, okay, why is it a 4 and not a 2? Or I could say, what would it take for you to go from a 4 to a 6? All right, what would it take? You're at 4. What would it take to go to the next level up? What do you imagine would help? And then that kind of gets into, well, I could do this. I could do, like, it gets into kind of planning talk, which is also change talk. So I have to know both in order to understand the alignment between importance and ability to really put together a plan. But both parts are part of the readiness ruler. How do you respond to change talk? You ask for elaboration, you offer affirmations, you reflect, you summarize, right? It's essentially our same ORS skills. So here's just a quick summary slide on change talk: desirability, reasons, need, commitment, activation, taking steps, or darn cats, and sustain talk, which is opposite of change talk. And there's sustain talk, and then there's like discord. And discord is, I can't, I won't, I'm not interested, you don't understand me. That implies that there's an issue with engagement. There's an issue with the relationship. So I'm going to show 2 illustrations. They're both at a pediatrician's office. And I'd like you to tell me, what did you hear the interviewer do? How many questions? How many reflections? How many affirmations? And how many summaries? So QARS. How many questions, affirmations, and reflections and summaries did you hear? Any questions about this exercise before I show the video? All right. So the setup is there's a pediatrician talking to the mother of a patient.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, It seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. He gets really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so, what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I mean, I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard. So I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand that. I know it is. I mean, everybody has problems, right? It's really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll find, I guess I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Okay. Whatever. Okay.
Okay.
How did that go? What did you notice?
To hear or repeat any of the statements that the mom was making?
Very few reflections. Odelia says, yeah, it wasn't good. The pediatrician wanted the change, but not the patient. Well, here's the question. Did the patient, oh, in this case, it's the patient's mother. Did the patient's mother not want to quit? What did you hear her say?
I heard her say that, yeah, she wants to quit, she just doesn't know how. So
That's right. I
was
want
an
to quit.
opportunity.
It's just so hard. And what did the pediatrician do in response?
There are so many things out there to help you. I can't understand why you would not quit.
Mm-hmm. That's right. So go do all these things. Well, here's another question. Who is doing, yeah, that's right. In this case, the mother was defending the status quo, giving a lot of sustained talk. I would argue that that's probably because the pediatrician was pushing. Who is doing most of the work in this instance? Yeah, the pediatrician. So here's the thing, like, the pediatrician was coming up with reasons to quit, coming up with a strategy to quit. Like, the pediatrician was doing a ton of work. And yet the patient's mother was like, nope, not there, not ready, at least not ready in the way the pediatrician wants her to be ready. So one of the ways that we can burn ourselves out as clinicians is when we're working harder than our patients, right? So sometimes I get asked, I don't have time to do all this engagement and focusing and evoking and planning. I don't have time for that. I might say, well, look, this is the way, if all you spend your time doing is telling people what to do all the time, and you don't spend the time actually understanding where they are, and really reflecting back to them what their ideas and values and preferences are, you're not actually going to get anywhere. So yes, talking to patients takes time, but it is time so much better spent than this way. Well, here's a question. What do you think the patient's mother is going to do after she leaves the office?
Like one up.
That's exactly. She's probably going to go have a cigarette. Exactly. Right. So she's doing a lot of work. The pediatrician's case is doing a lot of work kind of for nothing. You know what I mean? Kind of for nothing. Okay. I'm going to show another video, same exercise. So listen for questions, affirmations, reflections, and summaries, and then we will debrief.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now, I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you're able to stop, but
yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
Yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep, every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list, it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure.
So.
Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
All right, what did you notice in this interaction?
First and foremost, her tone was just even more inviting for engagement and connection. So that was awesome. And then open-ended questions were awesome as well.
So a better illustration of the spirit, right? What else did you notice? Yeah, there were a lot of reflections. She was using, many of us use questions. She was not using, I mean, she asked questions, but she used a lot of reflective statements. Right? Some open-ended questions, but most of what she did, I would say over half of the things she said was reflections. Right? So it was so scary for you then, it doesn't seem that scary for you right now. It's important to quit, but it's not making it to the top of your to-do list.
The summaries really drove the conversation as well. She summarized probably 3 or 4 different times, and that was really good.
And it moved it in the direction of change. Where do you think we should go from here? Yeah. So does that make, I just wanted to show these 2 examples, sort of next to each other. Does that make sense as kind of how we talk to patients about change? And ironically, do less of the talking. Ironically, we are in a position to do sort of less of the talking and more of the arranging of the conversation so that the patient does the talking. Any questions about this? All right. So, let's see. So what happens? It says microphone issue. Can you still hear me okay? Or I'll put it this way. I'm going to assume you can still hear me okay until you tell me you can't. So, but it looks like my transcription
We can hear you, but your screen looks different.
Huh, that's weird. Let's try this again. Does the screen still look different?
That looks better. Before we were on the presenter view.
Oh, weird. Sorry about that. Okay, so what happens if a patient is not giving you any reasons to change, right? So if the patient's not giving you any reasons to change, then it's probably time to find another topic. You have to be attentive to something called resistance, and we used to have this phrase in motivation review, roll with resistance. Resistance, the issue with resistance is it really captures two things. Sustained talk, which is when the patient says, I'm not going to change, I don't want to change, right? Like there's sustained talk elements. And then there's discord, which is your relationship isn't going well. So sustained talk is, reasons not to change. And you get, if you spend all your time getting sustained talk, like you get more of what you reflect. So if the patient, if all they're doing is saying why they're not going to change and you reflect that to them, they're likely to continue along that. Along those train of thought, which is why reflections can sometimes be that like pivot to the pinball away from sustained talk and into change talk. But you have to be selective at listening for what might be true for somebody that would be in the direction of positive change, right? It's like a dance, right? You're stepping in the direction of change as opposed to you have to quit. And I think listening to that first video, that was an example of a wrestling match, right? Of a wrestling match. So how do you respond to sustained talk? Simple reflection, amplified reflection, double-sided reflection, agreeing with a twist. Actually, sometimes if a patient just needs to get all of the sustained talk out, I might just listen to it, right? Like, what are all the reasons you love about smoking? Tell me everything about it. What do you love about it? What keeps you smoking? I want to know all about it. So that if you can explore that first, then you don't have to do that. I'm not saying this is like routine, but you sort of get that, understand kind of what you're up against, so that when you are listening for change talk, you can listen for it in the context of what somebody already likes about their smoking. And then there's discord, which is like the person's like, okay, yeah, whatever, right? Or you don't understand me, you don't know, you don't care, we're interrupting or disengaging. Plus, you can always apologize or offer an affirmation can be very helpful during a discordant part of the relationship. Or you might just say, hey, look, this is not a topic that it looks like we're getting anywhere with. So maybe I can bring this up next time and let's talk about something else. So here's the quick slide of spirit, which is partnership, acceptance, compassion, and evocation, processes, engaging, focusing, evoking, and planning, and then ORS, focusing, ears, and then planning. There's strong evidence of cross-cultural effectiveness for motivational interviewing, and here are the 5 things we covered today. 4 processes: spirit, change talk, information advice, and the ORS, the core skills. Don't skip engagement. It's I see this happen all the time, is, patients come in and the clinician spends no time sort of understanding where they are, and so sort of is like, okay, do this, do this, do this, and the person, it's just, they're not even connected. And it can be a lot of wasted time. So the most important step, if you're not engaged, you can't do anything else. So it's the most important step. A particular thank you to William Miller and with Steve Rolnick, who developed motivational interviewing. My own mentors and teachers, the Motivational Interviewing Network of Trainers, the Friends Research Institute that's been a vital support for this work, as well as DPH, Tobacco Control and Prevention, and the TRDRP funder for this grant program. And the people I learned the most from are my patients. This is my email address. What questions do you have as we transition into the next part of the morning?
In the second situation where the interviewer kind of summarizes the kind of conversation and says, well, let's make another appointment. At that next appointment, do you still spend some time kind of like reviewing like where they at now, assessing the situation again? Do you kind of just make a summary and see if they agree with that, and then let's jump right back into our conversation?
Yeah,
like
totally.
How do you handle that?
So I would start the next session by saying, last time we talked, you said that you were interested in looking at options to reduce your smoking because it seems so overwhelming. I just wanted to check in with you. Is it okay if we start with going through some of those options? And then, oh yeah, totally. Like I remember we talking about last time, totally ready to talk about options. Great. Let's talk about options that do fit into your life. And then we're off. You don't just have to, like, that summary can automatically give an idea as the person, are we engaged? Is that an area of focus that we agree on? And, I've used the patient's words. So have I done an accurate job of evoking? The person says, yes, I can kind of get right to planning at that point. And everyone says, well, no, I thought more about it. And, then if, like, I do need to still spend time listening. but I can use a summary to kind of like shortcut that for what I would start with next time.
Great, thank you.
No problem. Other questions? All right. You will get a copy of the slide deck. I think, Brianna, we have a PDF copy that we share with participants.
Yes, they will get that.
Great. And then are there any other questions from anybody at this point before we transition?
Yeah, I had a quick question, Dr. Hurley. Would you recommend, well, let me just frame it this way. If I can establish good rapport with the patient early on, do you recommend more evoking and more complex reflections, based on the rapport, or do you think it's safe to do those things even if the rapport isn't, solid or solidified yet?
So if you start doing complex reflections and you're getting change talk, you're doing it right. If you're doing complex reflections and you're not getting change talk, then you need to spend more time on rapport. But you should know within a statement or two kind of where the patient is. So nice thing about motivation, you get immediate feedback. You say something, are you getting change talk? You're doing it right. If you're not getting change talk, go back and figure out what's going on.
All right. Thanks for that.
Other questions? So I had mentioned her up front, but I see she signed in. Tasha, you want to introduce yourself briefly?
Hi, yes, I'm Tasha Dixon. I'm still working on my camera, but I'm Tasha Dixon. I will join you in a bit to start the Kick Ash curriculum training. I am a licensed marriage and family therapist, and I am the behavioral specialist on this TRDRP project. And so I'm excited to get into the curriculum with you all.
So Tasha, what time should people reconvene?
We can come back at noon, so a little over a 30-minute lunch, and then come back at noon.
All right, so you have a break until noon. Thanks and take care, everybody.
If you can let me know in the chat if you are back, that would be great. Yeah, Brianna, I could do that. If you tell me how to do it.
Oh yeah, so you go to the right of my name where the little three dots are. And then it should say make co-host. Oops. Are we doing breakout sessions today?
Yes.
Okay. You might actually have to make me host again.
What do you mean the right of your name?
Oh, do you see like the three dots?
Yeah. Oops. Is that good?
Yes. Yes, that's perfect. Okay, thank you.
Did you guys run Norma's video today?
Yes.
Okay, perfect. Let's say, use it as part of my your story. Let's see. Again, if you were back, please let me know in the chat. And we'll get started when the majority is back. So I only have one person saying they're back. And I probably sound low. I won't sound like that during the, I'm mumbling, I know, but I won't sound like that during the training. Hi, Ronald. Almost back. All right, guys, we can get started. I believe we're waiting on a couple of people, but we can go ahead and get started. So as I said earlier with Dr. Hurley, I am Tasha Dixon, and I'm going to do the rest of the training today, and we're going to get into the curriculum of Kick-Ash. And once we are done, you will receive the Kick-Ash manual that I'm going to go through, and you're also going to receive the participants workbook that the participants get when you are running one of the groups. I know you probably already have done introductions, so we don't need to redo them unless you really want to, but I would like to know what site you all are at and what you will be using, how you will be using Kick-Ash. If you're going to be a facilitator in a group, if you're going to be supporting facilitators, what your role in this will be. So anyone can get started. Anyone care to share?
Hi, I can go first. My name is Pen Tran. I'm a pediatrician. I work at H. Hudson Clinic, part of the ambulatory care group. I'm a pediatrician, so I actually wanted to sign up for this course to learn more about how to prescribe medications for smoking cessation, specifically because I do work in a with the pediatric population, more for patients who use vaping or e-cigarettes. So that has been very helpful.
Okay.
And as far as I'm aware, I don't think that our specific clinic offers a smoking cessation, like a 6-week course for patients, but it's possible that it exists and I just don't know.
Okay. Great.
So at Hudson, not yet. Hopefully one day. Right now we're sending people over to Hubert Humphrey from Hudson.
Okay, thanks.
No worries.
Anyone else? Thank you, Ron, putting it in the chat. You are an SUD counselor. I know, I'm very familiar with you over at Mid-Valley, correct? I believe. And then we have Ardulia Hernandez, clinical social worker at Wilmington Health Center from Coastal Clinics. And you're going to be a facilitator. Great. How about you, Francisco and Diego? Francisco, just here to learn about the program. Sounds good. SFHC. What is SFHC? Oh, San Fernando Health Clinic. Okay. And then we have, gotcha, Ronald. Then we have Diego at MLK, here to learn how to better support the patients. Great. Sounds good. I think that's everyone. I don't know if Eddie has made it back yet to share where he is and what his role will be. All right, well, we're going to get right into it. One of the things before I open up the curriculum I like to do is talk about the why we do this work. And I've come to find that a lot of people who take this training are doing this work because it's their job and they're being told that this is going to be a new part of their job. And so they're the selected people who will be taking this over at their site. So outside of that, think it's very important when we help people with smoking cessation that we understand the gravity of what we're actually helping them with. Quitting smoking is one of the hardest things to do. You will find participants coming to you or patients coming to you who probably have tried to quit smoking numerous times, who feel helpless or hopeless in the fact that they can quit smoking because they have tried different things to quit. So we want to just offer as much support as we can along their journey to quitting. And I call it a journey because that's exactly what it is. We don't push them too hard in setting a quit date and talking about quitting. What we push really hard is a reduction in their smoking and keep moving them on a pace that's realistic for them so that they end up not smoking at all. But we understand the hardship of it and how difficult that is to do, especially because smoking is one of many bad, well, I call them unhelpful coping skills. So to know that people are smoking, using it as a coping strategy for other things going on in their life, we have to be mindful that when we take away something, what are we replacing it with? So I hope that you see in this curriculum that we are replacing the smoking behavior with a lot of information and a lot of things that they can do and utilize as an alternative. But the why becomes huge. When it's just our job, it becomes mundane. And then we then send that message over to our patients. So I always ask that you kind of attach yourself to a history of smoking, kind of, you know, reflecting back on the video you saw earlier about Norma's story and all of the events of smoking within her family and things that you're seeing within the community, how important it is to see the struggle. The struggle is real when it comes to smoking. And so I want us to kind of delve deep inside of ourselves and see if there's any type of interaction or any type of relationship that you have with smoking. I am going to share with you my story. It's not a video. I wish I could have such a beautiful video, but it's not a video. It's just a story of my life. You know, I grew up with a mom who smoked. I don't remember her not smoking, but I do remember her multiple attempts at quitting and being unsuccessful. I also remember like lighting cigarettes for her and bringing it to her, going to the store and buying cigarettes for her. So it was a part of my life for sure growing up. When my siblings and I became adults, I remember us having more of a voice and being just very negative about her smoking, talking about how it smells, really just like not wanting to be around her when she was smoking, waving her smoke, and it was so annoying to her. And we pretty much really gave her a hard time. And in that process, she was still trying to quit. So I also know what smokers go through on a family dynamic. When it comes to if your family members aren't smokers with you, they kind of give you a hard time. So I know we did. And so that just sticks out with me. My mom did pass away of cancer in 2019. And she smoked up until chemotherapy. That was the only thing that took away the taste, and she took medication for chemotherapy where she didn't want anymore. But after diagnosis, a good year and a half after being diagnosed, stage 4 spread throughout her body. She just still couldn't stop. So again, proof of a coping mechanism, how that helped her cope with the tragedy that she was going through. But yeah, so that's my connection. That's my why, to help smokers understand that I understand that this is hard for them, but I also understand that they can quit and that they can be supported in the process. And so that's what I would like for us to do, is to offer that deep support for them and to continue to motivate them to stay on this journey. I'm hoping the curriculum is something that you find to be very like user-friendly, with skills for our patients to really start focusing on themselves in good ways, good and healthy ways. So that's my story. If anyone else has any connection to smoking, whether it's you, a friend, a family member, this is an open forum for you to please share. I do invite you to share your connection with smoking if you have one. Would anybody like to share? don't all jump at me at once. Take your time. I'm just kidding. All right, so nobody wants to share, that's fine. We're gonna move on into the curriculum. I'll share my screen to it. Let me pull it up. How do I get rid of? Can you see that? Yes? Okay. If you can't hear me, let me know. Also, I'm going to give you a quick check. Thank you, Tan. She did share in the chat her story. If you want to, feel free to go and read it. Good job. Thank you. Letting know you can hear me. Okay, so I'm going to preface this with if we were in person, this would be almost a 3 to 4 hour training. We have mastered condensing
Tasha,
it. Yeah.
I'm so sorry to interrupt you, Tasha, but we're having a fire drill, so I'm gonna have to. Yeah. So if I'm off, just know it's not me, and I'll try to jump back on as soon as I can.
No problem, Ronald. Thank you.
All right. Thank you.
All right. Bye. Ronald's been through this training already, so that's okay. All right, so I'm going to preface it with that this is a 3 to 4 hour training. We've mastered how to condense it into 2 hours, but part of that means I breeze through a little bit quickly. I talk fast, so I will make room for questions at the end of each session that we go through. And then I will have some reflection time after every third, like once we do 1 through 3 session, we'll send you out in breakout groups to reflect on what stood out for you. And then we'll do that after the 6th one as well. And please add any questions in the chat that you have, and then I'll make room for questions at the end. If I am going through it way too fast for you, please just shout out, to slow down, or put it in the chat. I can't really see the chat while I'm doing it, so hopefully my trusty colleagues on with me will help keep me up on that. What else?
Yes, we will.
Thank you. I think that's all that I want to preface with. Okay, so Kick Ash. This is a facilitator's guide manual. This exact manual that I'm going through is what you will be emailed at the end of our training. It is a cognitive behavioral approach for smoking cessation groups. It is a 6-week open group format. Open group means that participants in your groups can repeat them if they wish, and or participants can come in group 3 and have missed session 1 and 2. They can come in session 3 and you can just keep going along and it will be fine. Just remember that they started late and need to come back in to repeat 1 and 2 when you do it. So it's an ongoing group. So once you do 6 weeks, you will restart them over again in case you do have people who want to repeat. That doesn't mean after 6 weeks you can't take a break. People take 1 to 2 weeks, 2-week break before picking it back up, just making sure you remind those participants who need to come back in and finish or want to repeat. What else? I think that's it. So we'll move on. Bear with me because I've not figured out how to, maybe I have. Oh, that might be better. So in the beginning of your curriculum, you have a table of contents. In the table of contents, you can see that there are a ton of activities to do in each of the groups. So these groups are 60 to 90 minutes long, depending on how many participants you have in it. If you have multiple, anything past 10, you may move in towards a 90-minute group, but anything 1 through 8 people, you should be good in 60 minutes. But there's no way in 60 or 90 minutes can you go through all of these activities. So the curriculum was made for the facilitator to be able to pick and choose which activities best fit their style and that they're most comfortable with, or best fit their participants or the group that they're in front of. Every time I do a presentation or every time I do something, I like to tailor it to meet who I'm in front of. So your group may all have something in common or may, whatever. So you can change it up every time you run these groups. So you can choose an activity. It doesn't matter what activities you choose. They all are giving the same message in each of the sessions. And because it's a repetitive group that the participants can repeat it, this part is important. So if you find you have a lot of people repeating it, you get to actually do different activities that you didn't do the first round with them. So it feels new. What else? We're going to pay a lot of attention as we go on through each session to the names of the sessions for a reason. Also, when I say that you can pick and choose these activities, there are some activities that I will highlight that I say you should really be doing because they work really well, or just because they set send a good message, or set a tone for what we're trying to give them. So I will highlight what those are. What else? I think that's it for the table of contents. Now, this curriculum, what you're getting is for your eyes. It is not for the participants. The participants do have a workbook that you will be sent, and I'll show you at the end what that looks like. The workbook is just simply the pages that are handouts that you would give them, so they can get that up front from you. You just print it out for each of your participants. Here we have, and I see. The session overview. So basically, what this is doing is giving you what the participants will gain in each of the sessions. And then you have an introduction to each session. So here we are in session 1, Living Tobacco-Free, A Dream of a Lifetime. It's called A Dream of a Lifetime because in this session, what we're doing is prepping our participants to visualize themselves as smoke-free. So everything crammed in here is giving them information or giving them a visualization of themselves as though they didn't smoke, as though they've already quit. The purpose for this is early on in the beginning, we want them to imagine being smoke-free and what that would be like for them, so that it motivates them for them to really reach that goal. If they can visualize it, then they can have it. What is it called? If you can dream it, you can have, I don't know the saying, but but there's a saying. And I think that that's important for them to be able to start talking about what life would be like smoke-free. The introduction gives you just some information about how to set up the group, how to establish the group. In this first session, it talks about facilitators establishing the group to being safe and open in an open, friendly environment. The vibe that you give as a facilitator is the vibe that the people in your group are going to pick up on and utilize while they're in the group. So being energetic, being motivating, and being positive about their journey will help them and keep them engaged. So we're going to go into the first activity for session 1, which is establishing group rules. This is what I'm highlighting as one you should definitely do, just so that you establish something up front that allows the participants to kind of have some say-so in. Like, you want to engage them into setting up the group rules so that they feel like they're a part of this group, that they have a say-so in this group. And if they don't come up with the things that you want to set, like being on time, no cell phones, or confidentiality, then you also can come in with those particular things. But we also want to hear from them. I've included what I call the group contract, just having the participants answer 3 questions. How would you want to be treated by the leader of the group? How would you want to be treated by the other participants in the group? And how will you treat others, including the leader of the group? Once you get them to answer these questions, you can go around and have everybody blurt out answers. And I like to write it on a big sticky paper, and it's called a contract. You can have them sign it if you wish, so that they are not bound, but I guess bound to the rules or aware of the rules. Every time you come in a session, you can bring out the rules, just post it. You don't have to go over them. Unless you have a new participant in a different session, then you want to quickly go over them for the new participant. And then they get the questions here so they can answer them on their own in the group, and then you can open up a discussion. The next activity is a self-visualization activity. Basically, this is allowing participants to really hone into what it would be like to be smoke-free. So what I have here is I've written out for you the exact words you can use in the visualization. So I don't know if you've ever led a group of people in a visualization. If you haven't, it's all right here. So in a calm tone, you're just going to change the tone a bit in a relaxing state and invite them to close their eyes, relax their body in their seat, make adjustments in order for them to feel comfortable. And then bring in some silence in the room, kind of really rev them up. And then you're going to go through the prompts here. And even all that is written in that first, the instructions to participants, even that is all written for them, for you to recite as far as closing their eyes and getting comfortable in their seat. But basically, we're going to have them answer some questions like, how would I feel if I didn't use tobacco? How would my life be different? And then they can be specific in thinking about moving forward. What types of things would they be doing if they didn't need tobacco? What activities would they engage in if tobacco was absent from their life? How would their relationships with family and friends be without the use of tobacco? And what might you do with the money that you save now that you're not purchasing cigarettes? So again, we're getting them in a visualization about a smoke-free life. You can bring it back to discussion once you bring them back to opening their eyes and refocus to the group. And then you can discuss with them what came up for them, some of the things that how they answered some of the questions, and getting them to start talking about what that felt like and what they imagined for themselves, being smoke-free. The next activity, and the self-visualization is optional. It's one to choose from along with this one. So it's called Dear Future Self. What we're going to do is we're going to instruct participants to write a sincere letter to their future selves. And here are prompts for you to give to the participants about how to do this letter. And we're just going to have them answer questions about where they are for their smoke-free self in 6 weeks. So basically, they're going to talk about the accomplishment of quitting or reducing smoking, giving themselves words to their smoke-free self, being proud of themselves, just writing a sincere letter to themselves about going through this journey. Now, one of the things at the end of this activity you want to do is make sure that they write the letter, seal it up. If you're doing in-person groups, then they should I suggest you take the letters from them, and then, because we do revisit them in session 6, and then you bring them back in session 6 for them to be reviewed. If you're doing a virtual group, I also suggest that they put it in a safe place, but they also tell you where they put it, and you write that down so that they can remember in the next few weeks. Now, if you had a participant who missed this group and we're coming into session 6 and we're going over these letters, that's fine. That participant or those participants will just sit and listen through this process, because there's still a lot to gain from hearing other people's letter. I don't know if people are sharing their letter verbatim, however you want to do it, but I think there's still some beneficial points in hearing what other people have to say about this. All right, and this is actually with those prompts at the top. This is a handout that they get that actually is the letter that they can write right here on this page. So this is one that I will say to do. That is like I don't want to give it the term mandatory, but the reason why I say to do this one, because it has so much helpful information that people aren't aware of what happens in the body after they quit smoking or in the journey of quitting the smoke. And I highly recommend it because we have gotten really good feedback from this particular handout and going through it with the participants. So basically, it's the health fact sheet and information, and it looks like this. I'll bring it up a little bit. And you can go through it with them, and I want to kind of go through it with you a little bit just so that you can be aware as well of things to even look for as you go on in your group. So the first 20 to 30 minutes after their last cigarette, blood pressure and pulse drops, hands and feet start to warm up. 20 to 30 minutes. 8 hours after their last cigarette, carbon monoxide in their blood drops while oxygen level increases. So I believe all smokers go through the 20 and 30 minute period. I hope that they're not smoking like every 5 minutes, but that's something that they're not aware is actually happening in their body. But when we bring it to awareness, it's something they start to look at and look for. So the 8 hours, carbon monoxide in the blood drops while oxygen level increases. At 48 hours, senses of taste and smell improve. At 72 hours, bronchial tubes relax. 2 weeks to 3 months, circulation, lung function, and stamina improves. And then 1 to 9 months, I can't see that, coughing and sinus congestion decreases, lungs are better able to clear mucus, keep clean, and reduce infection, and their overall energy improves. So I'm going to stop there and say, while they're with you, that whole half of this sheet are things that they can experience as they decrease their smoking and or quit, right? If they are really doing the program and wanting and not smoking anymore or decreasing, they can have the ability to experience all of that within your groups, because the groups are what, 1.5 months. So they will have the ability to experience that. So then it goes on to tell you what the changes in the body are at 1 year, 5 years, 10 years, and 15 years. And it just talks about how you're bringing your body back to being risk, I guess, statistics of that of a non-smoker. So for instance, the 5 years risk of stroke is the same as that of a non-smoker. So the different changes, 10 years, lung cancer risk, half of that of a smoker. This is important to go through with them as well, because again, if they do achieve quitting smoking, it's important that they understand the longevity, how we're improving their overall health and their overall lifespan, the longer that they stay smoke-free. And I believe that may be it for session 1. Oh, no, sorry. One more. This is also optional, core beliefs. This is similar to the self-visualization activity. So core beliefs, basically, we're talking about how they believe. The core beliefs are the beliefs that they hold about themselves, and they also believe them to be true. So we're going to track their core beliefs because they're coming from a place of self-reflection and how they see themselves. But most times, or a lot of times, others see us differently, and oftentimes others see us better than we see ourselves. So we go through a reflection of present day. Take some time to think about yourself and how life is currently for you, and answering this following questions. Like, what do they think about themselves as a person? What is someone else close to them? How would they describe them? What are your strengths? And what do you love most about yourself? And then we do a self-reflection of the ideal self in the not being a non-smoker. So then they answer the questions of envisioning what it would be like to what it would feel, how they would feel about themselves if they no longer use tobacco. And if they were tobacco-free, how do they think others would see them? And what are their strengths tobacco-free? And what would you love most about yourself if you no longer use tobacco? So the goal here is that we want them to understand their current core beliefs are how they answered the first set of questions. And the ideal questions are what they desire to believe about themselves. And the hope is that through this process, they will get closer to their ideal tobacco-free self. And this is also a handout that they get. Any questions about session 1? Okay, we'll move on to session 2. Session 2, here is your introduction. The first activity, oh, sorry, let me go back to the name. So session 2 is embarking on a tobacco-free journey. The first session, Dream of a Lifetime, we've got them visualizing themselves as being tobacco-free through the activities that we do. In this session, we're embarking on a tobacco-free journey. So we're just starting off with like jumping into this journey of how to meet those amazing things that they've visualized themselves as, right? So the first activity in this is identifying triggers, helping them kind of attach to what triggers them to smoke. Why do they smoke? What leads them to smoke? This is helping us to gauge what it is that's surrounding the smoking. So this curriculum, I have to tell you, isn't a curriculum that targets their actual smoking. What it targets is things that they're using, the problems in their lives or the problems in their minds or whatever is happening with them that causes them to smoke. Because if we can get people to quit smoking just by attacking the smoking, then I think we would have less people smoking, but it's more complex than that. And so we want to kind of help them understand themselves and their lifestyle and what's happening on a day-to-day basis and come out of the routine of when something happens or they feel some kind of way, they go to smoking. They're not addressing what's happening. And so we want to kind of help them do that. So here we're identifying triggers, asking them to take some time out to think about different times, activities, people, thoughts, and feelings that may contribute to their tobacco use. Like, are they smoking with the same group of people? Are they smoking on their lunch break? Do they smoke first thing in the morning on the drive to work? Like, what's happening in their life that's causing them to smoke or that leads to them having a cigarette? In this session, we're going to do a lot of talk about goal setting because this is basically what this session is about. Goal setting, goal setting, goal setting, because we want to teach them how to set appropriate goals on this journey and helping them to change their smoking behaviors. Here we have a tobacco-free starting points. I don't know if that was an activity. Hold on, let me see. So this is just information about goal setting. You can actually read this if you wish. There's so much more on goal setting in this chapter, so we'll get to it. This is just a quick introduction of it. So the tobacco-free starting points is to help the participants. So we did the triggers. And so with the triggers and finding out what's going on in their smoking behavior, then we can help them find starting points from that information. So the starting points could be anything: set a quit date, maybe they're ready, engage in healthy behaviors, reduce their tobacco use, increase support, maybe they need to track their tobacco use because they're unsure of how much they're really smoking every day. Maybe they can work towards using a tobacco cessation medication. And then I left 3 blank in case they have their own that they can come up with of where they want to get started. This information is important with the goal setting piece of it because we want to be able to really target areas for them that is fitting in their journey to quit. They do get this as a handout as well. More information on goal setting. And here is where we get into goal setting. I gave you a lot of information. This is a complex way. Some think that this is a complex way to approaching goals, but I want them to be as successful as possible. It's called 5 Weeks to Success, and it's derived by the 12-week year. It's a book. I don't know if you've ever heard of it or if you've read it. It's what I follow in my life. So basically, every 12 weeks, it's a new year. So at the beginning of 12 weeks, so starting in January, I make my New Year's resolutions, and then I break that down for 90 days and work towards meeting those goals. The next year happens in April, and I either see if I've met those goals or I create new ones. Even if I haven't met the goals from the first 90 days, that's fine. I can continue them because I know that through those 90 days, I've done work towards meeting it. So I'm on my way. So there is no sense of failure in this. So it's called 5 Weeks to Success instead of 6 weeks because we're implementing it in session 2, not session 1. And this is how we're going to do it. We're going to have them come up with a goal plan, basically just quickly shout out what they want to work on and then overall goals. We are going to ask them to do self-care goals, personal goals, and a smoking cessation goal. Again, going back to the reason of if we only just did a smoking cessation goal, we're missing out on other parts that may be a contributing factor to their smoking. And so the self-care personal goals will help them also build goals within themselves to help make self-improvement, to kind of reach some personal goals they never thought they could or just never really focused on doing. An example of a self-care goal could look like taking better care of themselves, putting forth actions to allow themselves to be kind to themselves, overall self-improvement. A personal goal could be financial, health and fitness, career, or education. And then a smoking cessation goal could be to quit or reduce use, or any of the things we talked about in the trigger starting points. So then we come down and we take the self-care and the personal and the smoking cessation and create an overall goal. So the self-care goal, meeting these things, would be to improve my overall emotional well-being by paying more attention to myself and my needs. A personal goal would be to be healthier and take better care of my body. A smoking goal, I gave 2 examples here. It's either to quit smoking or to reduce from 4 times to 2 times a day. So we're going to have them make these goals for themselves. It's not the exact goal here, but this is an example, and they will get this sheet to them. So immediately we're going to have them write out the 5-week goal plan and then do the overall goals. Next, they get, sorry, phone's going to ring on my computer. Next, they're going to get this handout. Well, this is another example for you. Once we complete those goals, the overall goals, we're then going to do key actions or tactics they can do toward the goals. So one of the things that's important for when we do the starting points, I think it says on there, is to help them identify what they can do towards meeting those goals, because this is where they're going to put things in action. So if the goal is, the self-care goal is to improve their overall emotional well-being, for this week only, they're going to meditate in quiet time at least 2 times a week, or put themselves first at least 3 times this week. For the personal goal, to be healthier and take better care of their body, there's 3 examples. They don't have to do all 3 of these. They're going to drink 4 glasses of water at least 3 days a week, or they're going to take a walk 3 times a week, or they're going to do yoga 4 times a week. And they decide what these things are going to be. What can you do towards that goal? And then the third goal, which is the smoking cessation goal, to quit smoking or to reduce, they're going to identify the times that they smoke just for this week. Maybe they don't know. Maybe they're not aware of when they pull out those cigarettes throughout their day. So they're going to identify them, write them down, and kind of keep track. And then they're going to be more aware of their thoughts and feelings before and after smoking, and keeping track by writing them down at least 5 times this week. So these key actions can be what's doable for them in the week. So now, when we're tracking their goals, we're not looking for them to have met the big goals. We're looking for them to have met these small, broken down key actions week after week, because these are actions that are moving them towards meeting the big goal. Sounds complicated, I know, but when I tell you it works, it does. They get this every single week. We want them to rewrite out their goals, because we want them to be ingrained and for them to understand what those goals are, and then write out the new key actions towards that goal every week. They should change every week as they make improvement. So the one about drinking 4 glasses of water at least 3 days. Maybe they didn't meet that. Maybe they did it 2 days. That's fine. They can choose to keep it at 3 days or add it another day and do 4 days. Once they've identified the times of days that they smoked, fine. They've done that. So now what's the next key action on that? So maybe I'm gonna not have my morning and lunch cigarette, right? We don't want them to put a key action as far as not have my morning cigarette. That's fine, but we want to also engage them with understanding how are they going to do that. I'm going to leave my cigarettes in my car so that in the morning, they won't be there for me to smoke. I would have to get up and go all the way out to my car to get them. So I'm just going to get up and get dressed and get ready. They may smoke in the car, but we've changed the ritual. We've changed the routine by moving the cigarettes. So things like that. Here, I think is something that you should be doing. I highly recommend it. I mean, I am going to say this is mandatory. Again, this is a CBT curriculum. So of course we want to, and I don't know if you all are familiar with the cognitive triangle, the cognitive behavioral triangle. Basically what it is our thoughts, feelings, and behavior. And it explains to the participants how they are all interconnected with each other and influence one another. And they each affect one another in both positive ways as well as in negative ways. So the good thing is that they can change or manipulate one by changing another. So for instance, if I have worried thoughts like I'm scared that I will never be able to quit smoking, that's my thought. That leads to me feeling down and defeated, which then will lead me to just keep smoking. So we want to evoke change at any level of these to produce different results. For instance, when I'm thinking worry thoughts, you can evoke change by replacing the thought with a more positive one, or just by adding a self-affirmation to it. Like, I'm scared that I will never be able to quit smoking, but I'm strong, and today is a new day to try. Just adding that piece to the thought will then lead to me feeling motivated, and then the action of me probably avoiding this next cigarette. Maybe I'll have one later on today, but for this one, again, I'm changing routine. So we're going to teach them how to manipulate these areas to make change and to feel better about themselves. I thought it was done. So coping strategies. We're taking away something when we talk about decreasing cigarettes and or decreasing smoking and or quit smoking. So immediately in session 2, we're going to give them the 3 basic coping skills, which is deep, slow breathing, deep muscle relaxation, and picturing a peaceful scene. Here is just information for you on how to do that and how to give them that and practice that with them in the group, so that if they're feeling like this is overwhelming or it's too much, then they can do it. It's also a great way for you to end your group after talking so much about those goals and helping them understand what it is that they're doing in those goals. Any questions about session 2? Nope. All righty, I will move on to session 3. So session 3 is called, I don't know why I can't see it. A tobacco-free journey, regulating thoughts. So again, we talked about the cognitive triangle. Here's where we get into it. So session 1, dream of a lifetime, envisioning themselves as smoke-free, embarking on the journey. Session 2, where we start really making goals towards quitting or reducing. And now we're in session 3, regulating thoughts. We're going to talk about their thoughts. Every session starts like this, reviewing goals set for the 1-week timeline. As time goes on, this should take you about 5 minutes to go through goals because they'll get the hang of it. This one may take a little bit more because it's their first time reviewing it and talking about their key actions and what they accomplished versus what they didn't and how to create new ones. But in this session, we're going to focus on helping participants reframe their helpful thoughts. And the facilitator should be able to recognize the core beliefs, the intermediate beliefs, and the automatic thoughts of the participants in order to help them focus and make change in their thinking. So here I have given, here's the goal sheet that they get. Here I have given you just some definitions of intermediate beliefs, rules, attitudes, and assumptions based on a person's core beliefs. Automatic thoughts, the words or images that go through a person's mind and just pop up. And we're going to help participants identify core beliefs and helping them identify unhelpful thoughts. This session is key to helping participants hone into their thoughts, and the facilitator's role will be to lead the group in identifying stressors and unhelpful thoughts that cause a barrier in their living tobacco-free. So what is causing a barrier to them quitting? So the first thing we're going to teach them is thought stopping. In this session, we are going to basically talk about how these thoughts are just, the thought stopping is for those thoughts that are very strong and really debilitating to their functioning in quitting smoking or any other thing that's happening in their life. What we want to do is help them understand that when these certain thoughts come up, we want them to be able to understand that the thought is ruining their mood, because when we have these negative thoughts, it's affecting how we feel as well. So we're going to identify it. We're going to help them tell themselves this thought is ruining my mood. And then they're going to think of another thought. So they're just going to be getting rid of a thought, the negative thought, and implementing a new one. Then we have worrying time. We're going to teach them how to set time for worrying, because most people worry throughout their day. Worrying kind of fills their brain as they're functioning throughout their day. And so what we're going to do is rewire the brain activity to help them have more control over when they worry. And so how they do that is they create a time for worrying. And it's basically just creating 5 to 10 minutes, writing down all their worries, setting an alarm, and then sitting there and looking at the list and worrying. So throughout their day, when they start to worry again, they can tell their brain it's not time for that. You have to wait till worry time. It's kind of like they're physically moving that around in a different part of their brain, sitting there for them to wait. We're not doing away with them, but we're just holding on to them until we can have time to sit there and worry. The more they do this, the more the brain picks up and understands, like, oh, so these thoughts are for this time. I have clients who are utilizing this 2 to 3 times a day. Some people worry extensively, so they need to do it more. Some people can do it just in the mornings, whatever. But every time they do it, they write a new list off, because what I was worried about this morning may not be what I'm worried about now. So I want to do a new list, and that way they can track the things that they're even worrying about, and then talking and telling themselves later on, like, what really control do I have over all of these things? Most people are worrying about, I've had a client who was worried about tsunamis, hurricanes, tornadoes. And I'm like, we are in California and don't even have those, but they have seen horror stories about them. And so now they're terrified, all in their anxious thoughts. So we're going to help them kind of reframe, move them over to a different time to worry about them. They're unhelpful. Here's a worry chart that they get to write all the worries down. Then we're going to help them with reframing thoughts. This actually is going to be helpful for thought stopping as well as reframing. So you can kind of loop them in together, or you could do this one first so that they have this list that they're going to create. So basically, we're going to help them increase thoughts that produce a better mood. So they're going to make a list of good things about themselves, and they're going to make a list of positive things about life. The reason for this is that when they have to reframe their thoughts, they can take the bad thought and kind of add to it, like we did earlier with the CBT triangle of like, I don't think I'll ever quit smoking, but today is a new day. We're reframing that thought. But this list will also help them create a new thought. It's stored in the back of the brain where they can have access to it to talk about the positive things about themselves and talk about the positive things about life to counteract the negative thoughts that come through their minds. They can post this on the refrigerator or cut out just this little piece, keep it in their wallet or whatever, so that they can have access to even reading it if they can't recall. So when we talk about reframing, we're going to help teach them how to give themselves credit, a pat on the back. And the purpose for this is most of the things we succeed in or we accomplish, even the small things, especially the small things, people don't see us doing that. We just are doing stuff and people are not witness to that. So we need to learn how to praise ourselves and give ourselves a pat on the back. We're also going to teach them how to hold everything and pause, give themselves a break mentally, pause and let their mind relax, and then allow their body to feel at peace. So all of these tips and all of these steps are very helpful. And then they have this list to kind of rely on to come back to a more positive place in thinking. Mindset, mindset, mindset. So the mindset is a settled way of thinking or feeling about someone or something, typically one that is reflected in a person's behavior. So most of our failures can be contributed to our attitudes about something. The good thing is that the attitude is a mindset and can be learned or unlearned. So here are 2 mindsets that we're talking about and helping them understand the fixed mindset and the growth mindset. We want to help the participants move from a fixed mindset to a growth mindset where they're open-minded, that they open up the beliefs about themselves, that they can make change and that they're not stuck, which is where a fixed mindset will have them. For example, I'm only good at certain things. I can be good at anything is the growth mindset in that thought. So really opening up their ideas about how they're thinking in such a closed, fixed state. Here are some questions for them to answer to help move them over from a fixed to a growth mindset, and then also to help them identify which one of these they have. If you get participants that say that they believe they have a growth mindset, there's a question for that here that asks them, okay, if you already have a growth mindset, what could you do to kind of expand that even more? I think that's any questions about session 3. No. Okay. So we have talked about session 1, a dream of a lifetime, envisioning what it would be like to be smoke-free. Session 2, embarking on the journey, which is primarily goal setting and introduction of the cognitive triangle. And then session 3 is regulating thoughts, honing into their thoughts, helping make change in their thinking from negative to positive, from unhelpful thoughts to helpful thoughts. So I want to send you all out to your breakout groups now so that you can, I want you all to reflect how, what stood out for you in the first 3 sessions and have a discussion about that. What stood out and why, and how you think it'll be helpful moving forward with patients. So we'll take about 3 minutes in the group.
Okay, I'm about to break them out. And you should be good to go.
Thank you. Okay. We're missing people, I see. So I don't know how that worked out for you in the group. I think only Abdulia and Francisco, no, and Diego were in a group, if I'm correct. You guys probably were in a group by yourself all that time and didn't know. So I don't know, let me know what came up for you in that session, in the first 3 sessions, and tell me why that stuck out to you. What came up in your discussions? Anybody? Did anybody have any questions from the first 3 sessions? Oh. The importance of making sure the team members are engaged in the activities. Nice, yes. Yeah, that's super important because, again, whatever energy you're bringing is the energy that they are going to be picking up on. And so being engaged in it is important. The importance of clarifying goals for the patient, the direct impact, yes. Was there anything else that came up or that stuck out to any of you in the first 3 sessions? All right, well, we will continue on and go right into session 4, which is regulating feelings. So again, we did session 1, dream of a lifetime, session 2, embarking, session 3, regulating thoughts. This one is all about feelings. The first activity is handing out the goal sheet, changing up those key actions for the next week coming, or this week that they're in. And then we move into identifying feelings. This is first because, again, when we did thoughts, we wanted them to hone into their thoughts. That's surrounding their smoking behavior. Now we want to talk about their feelings surrounding their smoking behavior. But before we do that, I want to know what my participants know about their feelings. There's so many people walking around who are not in tune to their feelings or have a hard time expressing feelings, so they don't and they move it aside. So the first thing we want to know is, what do you know about feelings in general? So here I've created a how I feel chart, and I purposely put feelings on this chart that you normally don't hear. If you ask somebody, how are you feeling? You probably will get 3 or 4 common feelings: happy, sad, mad, tired. It's rare that you get somebody to say, I feel accepted. I feel proud. I feel resentful. I feel supported. You don't hear them saying that they necessarily feel confused or uncomfortable or valuable. So I added those other feelings on here just so that they can see them. One of the things that I do with participants is kind of ask the question of like, which one of these feelings do you think you walk in the most? like on a daily basis? Which one of these ring true to your person? The reason why we really want them to get really engrossed in their feelings is because once they can have a good understanding of what they're feeling then we can go into talking about their feelings around smoking. This next activity is called Happy Thoughts and Pleasant Activities. We are in regulating feelings. Why are we talking about thoughts and activities? Which activities are behaviors? Well, I'm going to repeat this a couple of times in this session, where feelings are, when we're talking about the cognitive triangle, the one part of the triangle that we can't hit and actually go straight to and make change in is feelings. I can't wake up sad and then decide to be happy. Something has to happen to bring happiness into this sad part of me, right? So happy thoughts and pleasant activities then help change my mood, which are my feelings. So here I made a pleasant activities list, examples of what can evoke a better mood, like wearing clothes that they like, planning a trip, playing a board game, taking a nap, eating good meals, learn something new, just regular random little things that they can engage in as pleasant activities. And I try to keep it very light, very easy and accessible, things that they can do to kind of help make change in their feelings. So basically it's activity selection. We want them to do activities that they've enjoyed in the past, and do things that with someone that they like, staying busy by getting involved with a group or a club, or helping someone else, because that does evoke change in mood. Here we have activities list and tracker. This is where they write activities that are already in their life, that's probably not on that list, something that they are already engaged in, that they enjoy doing, and why they enjoy it. Now, there's a reason for this list. For me, one of the things that I do is I rewatch movies over and over again, and we're talking 50 times. I have seen Just Go With It with Adam Sandler and Jennifer Aniston. Like I can recite it right now, starting from start to finish, and I will still rewatch it. When I rewatch it, my husband just looks at me crazy, and he's like, "You are laughing at it like it's the first time you've ever seen it," because it is hilarious to me, and I could rewatch it over and over again, and I do. So the reason I would put that activity there, the reason why I enjoy it is because it evokes such a happiness and makes me laugh out loud so crazy, and I forget everything else going around me. The purpose of writing down why they like this activity is because when they're feeling some kind of way, for instance, if I am feeling bored or sad, I don't have to look at the activity. I want to look at why I enjoy it. Oh, this is going to make me laugh like crazy. So then I look at the activity, like, let me go do that. That's going to change my mood by engaging in that behavior. So it's important. And I think a lot of us do a lot of things that we like to do, but we never look at why we like to do them. And when we do that, then we can actually do those things to replace unhelpful feelings or negative thoughts and negative feelings. We can actually do something different to make change. All right, group facilitators guideline for leading participants. Oh, this is another visualization process. It's written out the same way. You can use these exact words. It's verbatim if you wish. You can make change in it if you want as well. But for some people, doing visualizations is not comfortable, so that's why I wanted to write it out for you. But this is basically helping them create a peaceful place. We gave them this as a coping skill in session 2, but this is this more in depth of helping them become in tune with their own bodies and in tune with their minds, is that if they're feeling really bad, they can take themselves mentally to a better place that they create. This is detailed. This is talking about creating a calming environment. In this visualization, we're asking questions like, where are you? What are the colors? What's the scene? Are there any other people with you? What have you brought with you to this place? So that when they can envision it for themselves, when they need it, all of those things are there for them. They can bring all of that into it. There are other ways I do this. I just wanted to do it this way because it was just more user-friendly, I think, for the curriculum. But yeah, if you have different ways of creating a safe place or a peaceful place through visualization, go by all means, utilize that. but we want them to really be able to take themselves back to a place that evokes a happier feeling or a more serene feeling if they're feeling negative. Responding to feelings. You can feel fear, rage, love, hope, etc., but you can't control when feelings show up. When something happens that makes me sad, I'm sad. So what is within your control is how you respond to feelings. It's natural to have a quick response to feelings, but some responses are not helpful. Helpful responses allow you to control impulses and act independently of one's emotions. So basically, if I am feeling some kind of way, if I'm feeling stressed, I'm gonna go have a cigarette. What these questions are asking them is about their self-discipline to change feelings, right? If I feel stressed, do I have the discipline to actually do something different in that moment? Again, probably do something different. So there's the activities, there's those pleasant activities, it's going to a serene place. If I feel stress, what else can I do besides smoking that is going to change my mood to feel better, right? So this question is helping them identify what's happening in their responses to their feelings that leads to smoking. Any questions on session 4? It seems shorter than the others, but I feel like they're more in depth because we're talking very, like when we go through all the feelings, I think that's going to take time. I think it may even take time for them to grasp their own feelings, things like that. So spend some time in these activities to really make sure that your participants are in tune to their feelings or understand that the change in the cognitive triangle to their feelings are the other two spots and not actually going at the feelings. No questions, so we can move on. So session 5, of course, is regulating behaviors. Of course, they're going to get their goals, write out the whole goals and the key actions. We should see major changes in these key actions. If they were just hoping to, if they were hoping to reduce smoking and they've done it drastically, then maybe you see changes in their goals. Now, remember, they have 3 goals: self-care, personal, and smoking cessation. They may have met the self-care and personal goals. My suggestion was have them make more. Continue it on, keep going, keep working towards yourself and building yourself up. So trigger behaviors into alternative behaviors. So again, we talked about identifying triggers. Now we're really going to do it on a behavioral aspect. And so we want to move trigger behaviors into alternative behaviors. And this is what that looks like. So I created a list of alternative behaviors for triggers specifically. So because we're in session 5, maybe again, there's been some reduction in smoking. Well, maybe they're having cravings for cigarettes, right? Or smoking or tobacco. So here are some craving buster ideas they can use. Drink water, eat a frozen snack, whistle or hum, run in place, doing something differently. Maybe they're isolating more. To avoid isolation, they can call a friend, write a letter, give somebody a hug, or just come out of their room. Maybe they need to distract themselves at home because home is a really high smoking point for them. They can do a list of things: checking their tires, do the laundry, clean out the closets, organize, bake a cake, make a to-do list. Keep hands and mind busy. This is on here because smoking, vaping, all of them have a hand, this like motion. So this is a habit. The habit is more than just the tobacco going into their system. The habit is this is a habit, so maybe they don't even really want a cigarette, but they're just so used to keeping their hands busy with the use of a cigarette that they're going to pick up a cigarette to smoke. So maybe they're thinking like, what could I do, right? Like something's happening. They're keeping their mind busy. So to keep their hands and mind busy, they can get a new hobby, knit, paint a picture, back up some photos, play games, do a puzzle, things like that. Be active. So there's a fear of gaining weight if they quit smoking. If I quit smoking, I'm going to gain all this weight. Well, they can just be active, go for a walk, eat healthy foods, work out, and incorporate this in their journey all along the way so that it doesn't feel like they're on a diet and it doesn't feel like they are they're doing something behaviorally that ignites like endorphins in their body, that doesn't become a worry for them. Get out and about. Maybe they're stuck and shut in. They can go for a walk, take a drive, ride a bike, try a new class. Oh wait, that was the be active, sorry. The get out and about, they can go window shopping, donate blood, go for a drive, take a day trip. And then embrace relaxation and treat yourself. This is a self-care change. These are lists of self-care behaviors to kind of give to themselves to help them feel better. Smile in the mirror, take a shower, practice meditation, get a massage, color their hair, take a nap, deep breathing, things they can do for themselves to uplift them. So we're going to bridge together the cognitive triangle here. During this discussion on behaviors and alternative behaviors, facilitators should take note of some of the cognitive distortions and beliefs that participants express in regards to their tobacco use. So again, we're basically just talking again about how the thought, behavior, and emotion are all interconnected and how we have talked about all of them. Now you can do this in a different, because I think there's another activity after this. So you can do this last after that activity if you do it. But that's because that next activity, I think I added it after this. But anyway, we want to just bring it back full circle or full triangle into talking about what we just talked about and kind of reflecting on what they've learned about it, how they can manipulate, I guess, one or the other to make change. And so we're giving them their own cognitive triangle so they can, in the moment of your group, can talk about what they're feeling right now, what they're thinking right now, and what their behavior is. Or maybe you can say, like, early this morning, go there, or go to last night. And what were you thinking? What were you feeling? And what did you do? You know, kind of helping them track how much control, self-control they have in choice of how they live their lives and what lifestyle they create for themselves. That's absent of smoking. So here's an activity called recognizing your behaviors. I think we are, again, this is kind of like what I talked about with the chart of like why these activities I like to do and why. I think we move in our day without thought. I think we move in our day and not pay attention to what's going on. So I want for them to be more mindful of themselves and more aware of themselves in every choice and everything that they do, because it gives a sense of like success and it gives a sense of like ownership and self-control being used in a good way. And so here, this is a chart that's going to help them realize that there are things that are already naturally happening, that we just let happen and aren't even looking at or are aware of, that then moves into a natural behavior happening. So what this is a chart of how we feel, the thought to those feelings, the somatic response, which is kind of like our natural, like a thing that happens within our body, and then a natural response. So basically the somatic response is our body is already telling us and making us aware that something's going on that maybe we aren't really looking at. That's the part I think we bypass and not really look at. If we hone into that somatic response of what's happening in our body, then when we do that natural response, we can actually either choose the natural or the helpful behavior to implement. So here are the examples. I'll probably go through all of them. We have happy. The thought is, this is great. The somatic response is maybe I'm walking around smiling. The natural response is that I'm laughing or I'm smoking, because people smoke to celebrate. The helpful behavior would be laughing or sharing good news with someone else. So what I can do to that natural response based off of me smiling and being aware that something's good is happening in me is that I can make change in the smoking part and doing it. But I also want to reflect how the natural response of laughing is also helpful behavior. So some of the things that we're automatically doing is helpful to us, and some things aren't. If I'm sad, the thought is, oh no, that's too bad. And the somatic response is sad facial expression. Maybe I'm frowning. A natural response would be to cry or to smoke. A helpful behavior would be to cry. I'm a therapist. I make people cry for a living. Crying, I'm all about crying. It's a natural release. It's helpful. And you may need to cry. And I don't want, I don't think anybody should stunt that in people. So if you need to cry, cry. Engaging in a pleasant activity. So the difference, instead of smoking, we're going to be engaging in a pleasant activity. We're taking charge for ourselves, how we're going to respond to these feelings, thoughts, or somatic responses that are coming up. So we only need to be aware of one of these things, either how we're feeling, how we're thinking, or the somatic response that is the natural body response that's happening. So for anger, I'm so mad. The somatic response is that I'm clenching my fists. And then the natural response is smoking to calm down, or hitting something or hitting someone. The helpful behavior would be calming exercises like deep breaths and meditation, venting to someone, or talking it out, or walking away. If I'm overwhelmed, I have too much on my plate is the thought. I may be getting headaches, I may be sweating, I may be feeling fatigue, and then I'll cry, get some rest, or smoking. See how getting some rest is a helpful, natural response. So use calming techniques, focus on something else, or get some rest is a helpful behavior. If I'm stressed, I can't keep doing this. I might be having headaches, fatigue, or jittery is my somatic response. The natural response is just smoking, because it does kind of go into the brain space and go into our bloodstream of like really calming down. Instead, I can do relaxation techniques. I can get some rest. I can talk it out. There are other calming things to do other than smoking. And so here we have some questions. Can they recognize when their body alerts them? You probably can go through these same feelings and ask them if they're aware of what their somatic response is. Like for anger, it's like, how can someone else know that you're angry? What does that look like? And maybe they'll say, I'm growling, or I'm making a face, or something like that. So they can be aware of what's happening somatically for them. What are some of your somatic responses? Same thing to the above feelings. So this is the same process that I just talked about. So we want to help them become more aware of self in this process. Any questions about session 5, regulating behavior? Nope. Okay, we're going to move on to session 6. So session 6 is living the dream. So we did a dream of a lifetime, envisioning it. We did embarking on the journey, which was goal settings. We did regulating thoughts, regulating feelings, regulating behaviors. Now, this is a session solely based on how to continue living the dream, how to stay on target, how to continue and to prevent slipping and prevent relapse and lapse. So basically, session 6 is all about lapse and relapse prevention. They're going to get their goal sheets first. Why are they getting a goal sheet in the last session, you ask? Good question. Because we're not going to review this with them. We're done. Even if they come back, we're not going to review this. We're going to go into session 1 again and start it all over. The reason why I have them do this is to leave them still working on self, still working on the journey. And the hope is that they continue doing this on their own, because it's so repetitive. It's something we're constantly doing week after week, that we want them to continue setting these goals for themselves. Setting new goals, putting out those key actions, really focusing on self-care, personal goals, and their journey of smoking cessation. Okay. So we have the first activity, which is lapse versus relapse. I define what lapse is. A lot of people I come across have never heard of a lapse. I had never heard of a lapse before I was trained to become a tobacco treatment specialist. So basically, a lapse is an isolated or single use of tobacco. So basically, if someone has quit smoking completely, and then they had a cigarette, just the one, and that's it. We call that a lapse and not a relapse. Whereas a relapse is a return to regular use of tobacco after a period of abstinence. So they quit smoking, and then they had a cigarette, and then more and more, and continued on a routine of smoking again. It may start off slow, but they are smoking multiple times, whereas it's an isolated or single use in a lapse. Both are very important because I think even in a lapse, there's a lot of guilty feelings that go along with that. There's a lot of feelings and thoughts, negative thoughts about self that go into having that could lead to a relapse. So to define this for your patients and your participants, it would be really helpful for them to know that if they had a cigarette, they can capture that reframe that of like, I'm not going to keep doing this. Like, this is just a lapse. I can get it back together. But if we do have a relapse, we also want to prep them for, one, prevention of a relapse, and two, what to do in case of one. So I have here where it says facilitators should reassure participants that relapse is common, but not inevitable. So I will say that that the risk of relapse during the first 12 months is over 50%. So that is why relapse prevention is implemented along this journey, because 50% is high. So it's common, but it's not inevitable. Relapse prevention starts now and not just after a relapse occurs, to help them along the way. And preventing relapse often involves learning to anticipate and cope with the challenges that often lead to the relapse. So again, focusing on what leads you to smoke, more so than focus on the actual smoking behavior. So activity 2 is relapse prevention strategies. This is just a bunch of information for you as a facilitator, but also even for your participants to hear and to know how to prevent, what are some strategies they can put in place. To me, the strategies are, I'll let you hear. So like the first one says, don't smoke. That's not a strategy, right? So avoid any tobacco use, but particularly in the first 2 weeks of a quit attempt. So if you have a participant that has quit, the first 2 weeks are crucial for them to avoid any tobacco use. So when we're talking about avoiding tobacco use, we're talking about all those things that we talked about in their trigger, their trigger state, right? Avoiding those behaviors. Do you smoke with people at work during the lunch break? Then that's what we're going to avoid. We're going to change up lunch breaks. Do you smoke so we're avoiding tobacco use, not necessarily just the actual, smoking of it, but actually avoiding environments as well that lead to that. We're going to help them identify high-risk situations. We're going to help them prepare and plan for ways to deal with high-risk situations when they occur. We're going to help enhance their self-efficacy through supportive relationships and behaviors that support well-being. And we're going to help them identify strengths within themselves that encourages and empower their ability to work toward preventing relapsing. So first, we're going to talk about high-risk situations and triggers. This is from an article. And so you can engage your group in identifying factors that can lead them to possible lapse or relapse, like what's going on in their life that can lead them to that. And these may be high stress components in their lives, or some way identify people or specific times of the day. It's important that participants are aware of what situations or triggers that will make it difficult for them to remain abstinent. But imagining these situations, they can prepare a plan to overcome their craving to use tobacco. So possible situations, which is from an article, negative and emotional state, meaning if they're angry, depressed, or have anxiety, those are leading to smoking. Interpersonal conflict situations, conflict or stress within relationships, arguing with their spouse or significant other or family members. Social pressure, influences by a person or a group of people who smoke or go out and hang out at a bar where smoking is. Outside, positive emotional states, being happy or joyful or wanting to celebrate. Lifestyle factors like their attitude, habits, socioeconomic status can lead to smoking or lead to a relapse. Urges, such as strong desire or impulse or cravings, can lead to a relapse. Now, I have to ask all of you, is there not one of these on this list that you have not experienced? This is normal people stuff. Negative emotional state. Everyone has them at some point. Interpersonal conflict situations. Everybody has them at some point. Social pressure. Positive emotional state. Everybody has it at some point, right? Lifestyle factors. We all have lifestyle factors. We all, so it's so like, how are you supposed to quit smoking if the odds are against you and these everyday normal things ain't happening in your life that lead to smoking? That's why it's so hard. This article has said that negative emotional state is associated with the highest rate of relapse. Most of our patients and participants are possibly having some form of depression or anxiety. I mean, just whatever their mood situation is the highest rate of a relapse. And negative emotions can rise when they're quitting. Like, how are we what even is that? So this is the level of difficulty that this is, and this is why we want to give them that information. This is why the goals are set for them to focus on self-care and personal goals in a positive way, because we really want to undo a lot of negativity that they have and are harboring about themselves in their life. We're going to have them write out high-risk triggers and situations causing barriers to them staying smoke-free. So what are their triggers and what are those situations? And then we're going to have them write out their supports and their strengths. What supports them during these times? What are some strengths about themselves that they know they can lean on in that? This is something they can post, keep handy, somewhere in sight. So when they're feeling really stressed or feeling some of those things, they have this to rely on, to utilize and reach out to those supports and strengths. We're going to continue to increase awareness and give them other options to reach out to for your area, for your site. I don't know if you have a specific resource for smoking cessation, but here, this is where we're giving them information and phone numbers to quit lines, Nicotine Anonymous, and any other thing through tobacco control that you can find to give them as a resource. To my Dear Tobacco Free Self review, we are reviewing the letter they wrote in session 1, excuse me, in detail, talking about, do they notice any differences, really having them read to themselves their letter, and then talking about where they were then to where they are now. Maybe they haven't quit smoking, maybe they've reduced, maybe they haven't reduced, but maybe they have improved their overall sense of self, their awareness, all kinds of things, and they're just on the brink of like going into reduction and quitting. There should be a difference in how they saw themselves then to how they see themselves now at the 6-week mark. If there isn't a difference, then you talk about it and you discuss it, and what else can we put in place that they can put in place to make that change. This is a powerful letter. Any questions about session 6? Okay, moving on. So I added a bonus session A and a bonus session B. They're very simple. It's not going to take me long to go through them. Basically, what they are is, so this is called From Journey to Lifestyle. So bonus session A is when you have, so again, because they're revolving open groups, and participants can retake them 5 or 6 times if they want to. A lot of the facilitators who started with us 4 years ago or however long ago are still working with the same participants. They may have quit and they're not working with them as like in depth, but I do know that over the time they were repeating groups. Now, this is so bonus session A is for that person who has demonstrated a mastery of the skills taught and continues to maintain a tobacco-free lifestyle, but continue to participate in the groups. And at this point, you're like, you can run these groups, right? We don't want to not, discourage them for coming, but we do want to better utilize them for themselves to feel more empowered. So basically what you're going to do is make this your helper. These are the participants that are so good with helping the other participants in goal setting, that complex goal setting situation, helping them identify triggers, helping them find ways to do some of the activities for themselves. So they become kind of your assistant in a way where you are using them in an empowering way to kind of help provide peer support. That both helps your group and the participants in it, but it also helps this person stay abstinent and prevent relapse because they are now gaining more mastery in a different level than just being a participant, but they're helping as well. Bonus session B is different. So this is if, again, you have a person that has gone through the groups once or twice or however many times, but they may no longer come to the groups or they may still come. But we're going to talk about what if they don't come anymore because they've quit smoking. They're good to go. And then one day you look up and they're back at group and you're like, what's going on? So they may confide in you that they've had a lapse or a relapse. The only thing that you do differently in bonus section B is no matter where you are, if they come in group 3, which is regulating thoughts, you do away with regulating thoughts and you go right into relapse prevention, session 6. Relapse prevention group can be given in the beginning, throughout, wherever it needs to be given. But if you have a person that comes to your group who have quit smoking, but are telling you they had a lapse or a relapse, you're just going to start group out with session 6. Nothing is lost. And then the next week, you go to session 3 and pick up with regulating thoughts. But we want to hone into putting these things in place to help that person regroup, get back on their journey, and start again, and invite them to do the groups again. And then you go to session 3, and then they repeat 1 and 2 if they need to. Any questions about bonus session A or bonus session B? No. Okay. Here are some resources you're going to have, places to write notes. You're also going to get the DHS expected practices. I know somebody mentioned about medications and prescribing and what that looks like. Here we have 1-800-NO-BUDS, some more supports and resources to give to participants. But here's where Dr. Hurley talked earlier about more detailed about medication, but this is just a quick, simple chart for you to be able to answer those questions as facilitators in a way, once you are, like, so you get participants coming in asking about medication. Now you're going to refer them to the prescribing doctor, but they may have more in-depth medication about the patch specifically and why is it not working, and you can ask certain questions. Here's some information just at your hand to be able to kind of figure out how to lead them and where to direct them. So this basically is telling you a nicotine patch, the milligrams for how much they smoke, I want to say. Yeah, so like how if they're smoking two or fewer cigarettes, then the equivalent of 2 milligrams of the gum or lozenge or things like that. And so it's that with the patch, it's that with, you know, depending on how much they're smoking, how to utilize a patch, how to take the varenicline and utilize it in the bupropion as well. But again, you're not serving as a doctor, you just want to be aware of these things. And so that if this comes up, you know how to direct them to their physician and answer questions on a basic level for them. Any questions about the practices? Oh, so here is where it talks about smoking history and what the milligrams are for how much they smoke. Same thing with bupropion and varenicline. No questions? Comments? Anything?
Hey, Tasha, it's Ron. I'm back. My only thing is, I don't know if you talked about receiving the curriculum and the handwritten manual for the participants as well.
Yeah. Okay. Yeah. So you're gonna get that immediately. Well, not immediately now because Brianna had to run an errand, but Brianna is really good at emailing that to you after session. So sometime today you will get that to your email. I do want to show you all the workbook really quickly. And Ronald, you have it all, correct?
You know what? I thought I saved it to auto drive, but I couldn't find it there. I can maybe search some old emails and see if I have it.
Oh, okay. No, she's gonna send it to you today.
Okay.
As well.
All right. Thank you.
All right. Let me show you what this participant's workbook looks like. It's the same type of cover, so don't get it confused. But it just says participants guide workbook instead of facilitator. And basically what it is, this is a contract for setting group rules, the Dear Tobacco Free Me letter, the smoking changes in the body, the health fact sheet and information sheet, core beliefs, notes for them to write notes on, the tobacco free starting points. It has the sessions at the top of when they'll be using these. The goal examples, the goals and all their goal sheets, another example of how to do that. So as you're talking with them, they can be looking at that. And then they have the cognitive triangle and all the information under it, notes, goal sheets every time, thought stopping, worry chart, reframing thoughts, fixed mindset notes. So everything that we talked about, they get as handouts. This is where it is for them. So you can print this out in the beginning of your groups and give it to everybody, or you just have it as a placemaker for yourself. And then as you go, you can print it out for them for each group. So you can give it to them as a workbook. You know, sometimes participants don't follow through and stay the longevity of the 6 weeks. Maybe they'll come to 2 and maybe, you know, phase out and not return. Do you want to give them a whole handbook if they don't return? It's up to you. If you feel good about the group and people are responding well, then you want to continue. Abdulia gave us a suggestion about patients. Oh, you're asking suggestions about patients skipping sessions. Would we include them upon return independent on what session the rest of the group is in, or invite them to begin within the group? I would just continue on. You don't miss anything when they miss a group. The only hard part about it, so if they're skipping sessions, you just keep going. I wouldn't make a change for those participants who are skipping sessions, because what if you have other participants who are consistent? You can't fall back. So just keep going and encourage them to make up those sessions, or to, you know, get them to retake it or anything like that. But you keep going. Don't change what you're doing for them. Any other questions? Anything else?
Can you hear me?
Yeah, I can hear you.
Okay, just for everyone that's on the call, we do have like these breathalyzers. They do kind of track progress for people that are trying to quit smoking. So they track how much carbon monoxide is in their lungs, and as they reduce, it goes down. It's a really good visual way for someone to kind of see how heavy of a smoker they are, and to track their progress as they continue their tobacco-free journey. If anyone on the call wants us to bring those to your clinic and for you to have and utilize, we have some available. So you can just put it in the chat that you're interested, and we'll bring them. We'll email you, set up a time, and we will bring them to your clinic so that you can use those with the patients that you see.
Yeah, those are awesome. And it does help the patients see where they are and see how they're making change along the way. And I believe if she's Ronald at Mid-Valley is, I think you can access this, right? Brianna, if we end, you'll still be able to see the chat, but I'll write it down just in case.
Until I get to where I'm at. So people can log off, and everyone can log off, and I'll still see the chat.
Okay.
That'll be good. But yeah, but let me know. I think I see one person so far, but let me know either. And you can also let me know in the email that I send out when I send out the participant workbook and then the workbook for you. And then Dr. Hurley's slides, you can also email me there saying you're interested.
Oh, you already sent them the workbook and the curriculum?
No, when I send it later.
Oh, okay. I was gonna say, see how much on top of it she is? No. Yeah, well, so she will send it.
Yes.
Okay. So if you don't have any more questions or anything like that, then we